Good morning. Welcome to the University of Texas at Arlington. Thank you for joining us, and thank you to those that are online watching as well. My name is Melissa Gardner. I'm the program manager for the OSHA Education Center here on the campus. I just wanted to give you a quick safety briefing. Restrooms are located out the back doors behind you as well as the door to your left. If you're looking for vending machines, you can go out this door back to the front where you entered in, and it will be on your left-hand side. In case of emergencies or we need to evacuate the building, we will do so through the exits that I mentioned in the rear and to the left. So also I've been notified that people are getting some parking tickets. If that occurs, please disregard. We have that situation taken care of with the parking police. So at this time, I'd like to introduce our Assistant Vice President, Dr. Lisa Linden.
Well, once again, good morning and welcome to the University of Texas at Arlington. It is an honor to have you here with us, and I'd also like to welcome the folks who have joined us via the web. We're glad to have you all with us as well. It's always a pleasure anytime OSHA has something important, pressing to talk about, that they turn to us, and we're pleased that we can be of assistance, so we're glad to be the venue for this important discussion. We're very grateful to all of the speakers and panelists. I'd like to say just a few words about our programs. First of all, our Federal OSHA Education Center. How many of you are familiar with our OSHA Education Center? Just a couple of you. We are the largest Federal OSHA Education Center in the country. We have classes all over Region 6 and really all over the world, and it's an honor to be of service. We train about 9,000 people in federal OSHA regulations every year. I'd also like to mention our Health Careers Institute. They were instrumental also in putting together this event. Our Health Careers Institute trains entry-level healthcare workers, certified nursing assistants, patient care technicians, phlebotomy technicians, this sort of entry-level health career. And we've got some materials at the table by the front door. We'd love for you to take some of those home, and if you find there's any way we can be of assistance to you at your job sites, at your facilities, kids, grandkids, nieces, nephews, send them our way. We'd love to help them with job-related training. I'll also mention specifically relevant to the topic today, our infectious disease preparedness and prevention training, and you'll learn a lot more about why this is important and how much we've worked with all of our county health directors, county health departments, to put on a program that will be very valuable to you. So thank you for allowing me some time, that you had a choice, to tell you about some of our programs. We're very proud of the services that we provide here. We couldn't put these events together without a huge collaborative effort. So for the folks at OSHA, many of whom you'll be meeting today, so I'm going to dispense with the introductions and get right to the meat of the subject, as well as the UT Arlington employees. If there's anything that we can do to make your educational experience here today better, please just let us know. Now, without any further ado, I would like to introduce John Hermanson. He is the Regional Administrator for Federal OSHA. The office is here in the Dallas area, and we are very, very happy to work closely with him. John?
Good morning, everyone. I'm very pleased to kick off our Ebola Infectious Disease Symposium today. The Occupational Safety and Health Administration has been working hard to put on this symposium today with the fantastic help of our partners at the University of Texas Arlington. They are always here for us and do a fantastic job. As you know, there became a whole new awareness of the Ebola virus with two healthcare workers at Presbyterian Hospital here in Dallas became the first two cases testing positive for for the Ebola virus originating in the United States. And since that time, OSHA's been working very closely with many state and federal partners to develop guidance documents, worker training materials across a variety of industries. Obviously, it's not just healthcare workers that are at risk here. Some of the others include environmental services, facility management, emergency responders, waste handlers. So hopefully today you'll learn more about infectious disease with our esteemed group of experts that we brought together. And many thanks go out to all of the participants and the presenters here today. So I hope you don't take up more of your time, but I hope you enjoy the day and learn something. So thank you very much for participating.
Well, thank you, Mr. Hermanson, and thank you, Lisa. My name is Travis Clark. I'm the acting Assistant Regional Administrator for Cooperative State Programs in Region 6. And basically, I'm just going to be introducing the fabulous people who volunteered to come and present to us today. And without further ado, let me go ahead and get started with Dr. James Reddick. He is the Regional Medical Director for the Department of State Health Services. So, Dr. Reddick.
Okay. Good morning, everyone, and welcome to this event itself. I'm going to try to give you an overview of what my experience is, but also talk about Ebola in general as well. Give you some, insight to the disease as well. And so, let me start here. As Travis mentioned, my name is Dr. Reddick. I'm the Regional Director, Department of State Health Services. Been with this department for over 25 years itself, in different capacities over that 25 years. So now, today I read some good news in the newspaper, and it's related to Ebola in Liberia. Supposedly, they discharged their last diagnosed Ebola patient from their hospital. So that seems like some positive stuff going on in Liberia. They became very aggressive on that situation. And so I'm sure they're still monitoring people. And they probably won't be considered Ebola-free until they've probably gone at least through 2 incubation periods free of any other diagnosed cases of Ebola. That's usually how it generally works. But there's still a big issue going on in Sierra Leone and Guinea that they're working on. Their numbers are decreasing. So the interventions of the public health system in those 2 countries are having an impact on decreasing the morbidity and mortality related to this disease. So hopefully, probably within maybe the year, if they can really control it, maybe West Africa will be free of Ebola again for a period of time. But the numbers are pretty staggering itself related to Ebola in Africa. So I just want to give you some numbers so far. So far, out of the total cases, suspects, probable cases, or confirmed cases through those 3 countries, Guinea, Liberia, and Sierra Leone, there have been 24,247 cases. Out of that, laboratory confirmed there's 14,449 have been lab confirmed, and deaths have been 9,961 cases. It seems like a staggering number itself from such a vicious virus that probably has a mortality rate in Africa of around 50%. So hopefully the public health intervention we're doing over there in West Africa is making a big impact for those individuals. So right now I want to just talk about the disease itself briefly. And briefly we talk about the disease itself. And the most common thing is fever that we look for. And this is an important factor with looking for the fevers, mainly because they're not really infectious to other people until they develop this fever. Usually this is the time that the virus is replicating more and more within their body itself, but they're really not infectious to other people until they develop this fever. The other things they usually generally have is the severe headache, muscle aches and pains, or some general malaise as well. They'll have weakness, and then they have fatigue. Then later on the process, usually this diarrhea will set in, usually 5 days into the process after they're starting to develop this fever itself. They'll develop vomiting as well. They'll have abdominal pain potentially, as well as they potentially could also develop hemorrhagic type of conditions. Then the most important thing is the incubation period is anywhere from 2 to 21 days, but the most prominent time that people come down with is usually between 8 and 10 days from being inoculated with the virus itself. And then general recovery depends on how early you diagnose these people, how good of oral hydration you give them itself, or IV support as well. Also monitoring their blood pressure itself, because, like I said, they have the diarrhea, so they become very dehydrated. Their electrolytes get imbalanced, so you have to do oral hydrations and change up their electrolyte balances itself. So you're probably giving them some oral rehydration fluids to potentially have potassium and some other key elements in there to help that person survive. And most of the transmission, this virus can be secreted through a lot of different forms, through urine, saliva, sweat, feces, vomiting, breast milk, and semen itself. But most of the virus load predominantly is in the blood itself. Then probably the highest loads are probably going to be in the vomitus and the diarrhea that occurs with these individuals. And so that's why if you get stuck by a needle that you could accidentally stuck yourself with someone that was infected with this virus, and you could accidentally inoculate yourself, there's probably a good chance you're going to come down with this virus itself. In Africa, there's an issue with the bats and some primates that are infected. At least in the United States, we don't have to worry about that issue. I don't think we eat bats and we don't eat primates, as they consider it bushmeat over there. The other thing in Africa too, we have to understand it's why their transmission is a lot different too. It's their cultural practices. Their practices are a lot different when they bury people than how we bury people and deal with the dead people in our country. In their country, a lot of these countries, it's very not uncommon that what they do is they bring them back into their homes, they bathe these individuals itself, they'll do these special rituals where they'll put a cup to the dead person's mouth, and then everyone shares it. So you have different venues there that you all could be transmitting this virus very easily. And so, especially if you're cleansing the body and you're not using disinfectant stuff, this body probably is, if they've been having hemorrhagic issues and or if they've been having diarrhea, the virus will stay around for a period of time. So these are critical issues that they've been trying to change the behavior in Africa as part of that public health intervention, is educating them more how this virus really is transmitted, what they need to do to protect it. That's why they try to bury these people very quickly after they die in Africa itself. Now, so risk factors. Now, healthcare people definitely, without a doubt, are going to be at risk. I mean, they're the ones taking care of these people. They're the ones taking care of them when they're probably the most sick. Or that's when they're having the vomiting. That's when they're having the diarrhea, and they have to, try to get blood draws on. They're the ones putting the IV lines in it itself. So healthcare workers are definitely going to be at a higher risk itself. And I think probably OSHA will talk about PPE a little bit more extensively, to protect yourself itself. But that's why healthcares are more at risk, and this is probably when they have the highest viral loads going on all together. So it's important for the healthcare worker to be very cautious when we're taking care of these patients. These are the countries that are affected, and like I said, hopefully Liberia will be off the list probably sometime this year. Things go all well there. But just shows you the magnitude of the situation in West Africa. We can control it there. The issue is we will control it throughout the world, so it'll minimize transmission. We are global people. People travel constantly itself. So disease is only a plane ride away, depending whatever the disease it is. Well, diagnosis usually is made by, blood confirmation as well, but mostly we wait for certain symptomatology before we start doing the blood work on these individuals itself. And even if they start fever, it might take them another 3 days before they build up enough of the viral load to be detected. So it's not unusual. So if we tested some individual that was exposed to Ebola, initially it's negative, but they're showing some signs and symptoms, you can't rule out other reasons for the fever and the malaise and that it's not unusual to retest them in 72 hours itself to see if they're still Ebola-free or if they've finally shown that the virus has been detected. These are different forms of their tests that are used itself, but usually most of the times what we're doing in the labs we have is usually PCR. A lot of these other ones are antibody tests and stuff like that. But PCR is actually detecting the genetic makeup of the Ebola virus itself. It's a useful tool too. We use PCR too because we can do cycle times, which gives us indication about their viral loads itself. So during the Ebola event here in Texas itself, I guess, Texas right now has diagnosed 3 cases of Ebola itself, and New York diagnosed 1 case of Ebola itself. So Texas is probably leading, right now in diagnosis of cases itself. But here's what usually happens. So our lab had the capability to do the PCR testing itself. So it's not unusual that those samples will be sent to Austin for testing, and then also to CDC. Initially, without what's happening, there was 2 samples being sent. One was being sent to our lab in Austin. The other one was sent to the CDC for confirmation. Later in the process, during this event, the Dallas County lab got certified to be a testing site as well. That was sort of farther down the road itself before they became approved. And they had to get approved. Someone from the CDC had to come there, look at their facilities, and they had to go through some protocols to be eligible and authorized to be an approved lab for that. What they do in this situation, they'll give them positive samples as well as negative samples, and so that's one way of them testing. They had to do that multiple times. They had to watch how they do their procedures, making sure they're using the proper protective equipment during that time itself before they got certified as an approved lab itself. Now the difference between the state lab during this time was that the state and the Dallas County lab only had 1 marker itself on the Ebola for the PCR testing. The CDC uses 2 markers. Part of the reason why they use the 2 markers is just to minimize, for us, 1 marker. So the issue was potential cross-contamination. That's why the CDC uses 2 for the confirmation itself, because they want that to rule out any cross-contamination issues. Usually what you find in these individuals when they get hospitalized is usually they have what we call thrombocytopenia, which means they have a low platelet count itself. They also usually have a low white blood cell, leukopenia, a white blood cell count itself. And then they also have a slight elevation of their liver enzymes itself. And then they might also have some electrolyte abnormalities that's caused by this fluid shift that potentially occurs, especially if they're developing some diarrhea or vomiting. Then they also could have prolonged PTs and PTTs. That's related to how you coagulate your blood. So that's why some of these people can develop some hemorrhagic situations and get like what they call petechiae rashes and things like that. We have these little splotchy rashes with the capillary, the blood's leaking out of the capillaries. They also can leak out protein in their urine itself. As you're aware of, there is no true technical treatment. There's a lot of experimental stuff that's going on. So I think you've heard on TV and stuff like that. So they're all still experimental. They have not been approved and authorized. There's testing going on right now, I know, for vaccines over there. There's also testing of plasma itself from people that have been infected with Ebola and they survive. So they've been pooling plasmas itself and trying to do plasma studies on controlled levels of titers of plasma and giving that to people that have recently been infected with Ebola, see if that works. So there's a lot of stuff going on research-wide, probably over in West Africa at the present time. There's some medications being looked at as well to see how well they do to help increase survival rates there. But the most important thing is the fluid load. They're trying to adjust that fluid load, be it oral and IV or both itself. Make sure you maintain a good oxygen level itself and your blood pressure. Those are the main things that we can do for these individuals. Now I'm going to sort of go over the timelines, what happened here in Texas itself. So on 9/20/2014, Mr. Duncan arrives from Liberia to this country. Then on 9/24, he starts developing these symptomatologies of fever, malaise, headaches, and some abdominal pains. Then on the 26th, he goes to Texas Health Presbyterian with those symptoms, and then is discharged on antibiotics itself. Then a few days later, on the 28th, he returns there by EMS services with worsening symptoms at that time. And then the infectious control practitioner at the hospital called in Dallas County Health Department to investigate this as a possible Ebola case. Then the CDC Emergency Operations Center was called regarding this patient, as well as our main agency, or Department of State Health Services in the central office in Austin was notified of the situation as well. Then on the 29th is when some laboratory specimens were sent to the CDC in our lab in Austin. Then on the 30th, Mr. Duncan was diagnosed with the Ebola virus itself. That both tests, from our lab as well as CDC, showed out to be positive. So then we started to have to go and get an initial list of community contacts. That's what mostly Dallas County was mostly involved initially with Mr. Duncan's investigation itself. So they were trying to obtain all their contact information and all the people that he was in contact with. And so when we're saying contact, probably anyone that shook his hand was closer than 3 feet to him would be considered a contact. And then the more exposure you had with this person, as you're probably aware of from the media, like his fiance was probably more closely involved with him itself. Probably whoever was staying at that house were more closely involved because I'm sure if Mr. Duncan was having vomiting or diarrhea, they were probably assisting in cleaning him up at times itself or cleaning up the facility. So there are certain ones you get more concerned about, but all of them get put on a list as potential contacts, and then you start the monitoring process itself. So then on the 8th of October, Mr. Duncan dies of the Ebola virus disease. Then by the 11th, the Nina Pham was the first nurse that was diagnosed with that. She came back with a low-grade fever and this general malaise symptomatology, and so she was tested and turned out to be positive as well. Then on the 15th, Amber Vincent was, I think her name was, that was diagnosed with Ebola virus itself. And she came back from Ohio. She was planning, I think, for her wedding itself. She was out going to Ohio for that event. And so she came back on the 13th itself. And so now we have a flight that was, potentially exposed, but because I think her symptomatology was just sort of beginning about that time, the general malaise itself. I don't know if she was have a fever at that point in time, but she was starting to have some symptomatology. Then, as we're talking about all these contacts, so what happened is you had 177 community and healthcare workers that we were monitoring during this time. We finally completed that on the 17th of October. But this is where public health interplays throughout this process, where these people just didn't live in Dallas County. They lived throughout the Metroplex. So it was important for us to get involved during this period of time. We had to inform Collin County because they had a very high load of healthcare workers that lived in Collin County. We had some that were in Denton County. We had some that were in Tarrant County. We had some that were in some of my regional counties that were responsible for itself. So we had to monitor all these people itself during that period of time. And let me go over a little bit more about that so get a better picture of what goes on during this event itself. So during this event, we monitored them twice a day. And initially, some of us were just doing monitoring by like Skype and FaceTime, things like that. And we would see them and they would show us their thermometer itself, saying, here's my temperature itself, and we go over the list of those symptoms I was talking about, the nausea, vomiting, headaches, things like that. We go over those checklists itself. And that was done twice a day. Then at a certain point, Dr. Lakey insisted that all these people had to have one face-to-face meeting. You go into their house and meeting with these individuals. So now we're talking about a lot more time involved. You got to drive from person to person's place. Some of the healthcare workers, it was easier. We did it because they were still working at the hospital. So a lot of times when they checked in for their for work, they would come in there before they started work and get their monitoring done, or just before they left their shift, they would come get their monitoring done. We had an operation at Texas Presbyterian Dallas. OSHA was there. There was rooms for OSHA, CDC, Dallas County. We had regional operations there. Our regional health department staff was there. So there was people all occupying this one section of this hospital wing itself. And they were starting from 7 in the morning. They didn't sometimes leave till 9 o'clock at night itself. So it was like continuous operations. Also, that what was going on during this time was Dallas County had their own emergency operations center operating there too, because there's a lot of parts that are moving in these events. It's not just monitoring people itself. It was like, how do we get rid of the waste itself? How do we ship the waste down? What's the rules and regs related to that? Getting people to drive down. Some people were very fearful of driving a truck that had waste in it, but it was double bagged and super protected stuff, driving it down. Because it had to be drove down to the Galveston, if I recall it correctly, where they incinerated it down there at the UTMB. A lot of this waste was incinerated down there. So there was a lot of moving parts. When Mr. Duncan died, was coordinating how to get him cremated itself in a quickly, timely manner itself. Supplies, logistics. If certain people needed certain things, how do we get that supply or that thing that they wanted over to the individuals that needed it? The issue related to Bentley the dog. Who can forget Bentley? That became a big issue. They had to have, special teams going in there to just look at that, how to cleanse those facilities, those apartments itself. I was involved just in trying to educate the risk factors to these people, try to, they're using their total protective stuff, but some people were fearful of going into the apartments itself. So there was a lot of fear going on, and there was trying to do a lot of education to people to help them better understand this disease. It's a very deadly disease, but it takes you to have direct contact with these bodily fluids to come down with the disease itself. So, and it's hard to dispel these fears. If someone's just driving something, they're not even touching the stuff, then it was hard to really dispel some fears in certain individuals. So these are going over some of the numbers here. Then by the 21st, I think we finally whittled down the airplane contacts. Even all the air people that flew in those airplanes had to be monitored between the state of Texas and Ohio. So there's a lot of moving parts that are going on, and a lot of conference calls itself. So by I think we're by the 4th of November, we finally finished all the airplanes. Now we're talking about 2 months, we're dealing with this issue. And then, so finally by, I think it was the 7th of November, we finally finished all the healthcare workers related to the hospital itself, because when you have to do the 21 days, so when, I think, trying to remember, Vincent or Nina, whoever the last patient from that hospital left, whoever was taking care of that nurse that was the last one to leave, still had to be monitored for those 21 days itself. So this talks about what the role of our agency was. We were more a supportive role for the local health departments. We would either have conference calls with the health departments. My chief epidemiologist would be talking to the various health departments on the monitoring, because what they had to do when they were monitoring, the health departments had to feed that information into the regional office, which was Dr. Cervantes and our staff, and then we would feed that back into our central office as well on the monitoring, and then we would supply that to the CDC itself. Conference calls. It was constantly having a conference call about this, discussing what was going on, what's the latest, what's the newest information itself, anything changes in the protocols, we had to change itself, like I told you the one before, where we're doing twice a day, but it was more by Skype and that, and well, now it changed, you had to go actually and physically be there in front of them. Granted, and you had to take that precaution, you had to be 3 feet away from the individual itself when you're doing that face-to-face. So we had to draw up staff to assist Collin County. We asked for assistance because they didn't have enough staff to go see all these healthcare workers. So we had staff from throughout our agency from different parts of other regions, central office come up to assist that health department or any other health department that requested assistance during this event. Control orders. I had to hand a couple of control orders to people. We had to hand control orders. Our staff at the hospital, we control orders. Once the nurses came down, we put on restrictions. I guess best it wasn't truly a control order. A control order is a more official thing, but it was restrictions. So those they restricted them from going to certain places. They couldn't go to movie theaters. They couldn't go to the here. They couldn't take mass transit itself. So we have restrictions. So if they violate those restrictions, then we can go put a control order on the individual. We ended up have to put control orders on 2 people where we really restricted their movement totally. So they were being monitored, and local law enforcement was making sure that they didn't leave wherever they were designated to stay during that 21-day monitoring. The Emergency Operations Center for the Dallas County, as well as our agency down in Austin, like I said, we had to deal with the waste disposal issue. How do we get the waste down there? I forget how many truckloads it was. It was 7 truckloads of waste that had to be shipped down there for destruction. So, and then the issue about finding contractors to go out into these apartments and try to disinfect those apartments itself so they can be habitable again. Then dealing with Bentley, then we had to coordinate with Texas A&M and the Animal Health Commission, various people, CDC, just to deal with, well, we don't know a lot about dogs and Ebola, so the dog had to be monitored for those 21 days as well itself, and the coordination of that issue. So, so we had various people designated to do certain things, to work as a group to get a clear answer and decision made on those various issues itself. So we still talk about travel restrictions. We are still dealing with Ebola right now at the present time. We deal with travel restrictions. So any person that comes back from those 3 countries right now, we label them as high risk, some risk, or low risk. We don't see any high risk because high risk is considered when it's really been exposed to the virus, truly exposed, like a needle stick or something like that. Some risk would mean someone is taking care of a Ebola patient itself, but there was no breach in their protective equipment itself that they were using. And low risk is someone is just traveling or didn't have any exposure. They didn't attend any funerals or anything like that recently related to an Ebola patient. So we monitor these people as they come into the country, and we probably right now in this region we're probably monitoring, I'm estimating 15 to 20 people. Various health departments, that's their responsibilities to do twice-a-day monitoring. Now the monitoring restrictions are different for the some and the low. The some definitely have to get a visual checkup once a day, versus the low risk just needs phone calls and things like that. That's for twice a day, and their temperature monitoring as well as symptom monitoring. And the some risk have work restrictions. They cannot take care, if they're healthcare workers, they can't go back into the healthcare settings and take care of patients. So there is restrictions for those. Low risk doesn't have any restrictions itself. So I guess my take from my experience from this event and some considerations for healthcare workers should take home is one thing is that they need to do is look at a buddy system. And a buddy system is where it's two people, it's not just one person. So you have one that's the observer, one's watching the person don and doff their equipment and making sure that they're putting on the equipment right and taking off. But also while they're taking care of the patient, they're monitoring the person taking care of the patient itself, the nurse or whoever the healthcare worker is, and seeing if they accidentally do something wrong. Like, oh, you just touched the vomitus over there. You need to clean your glove off. You need to spray that down and disinfect that out. So, because we do things sort of, we're hoping that what the shield we have on us protects us. And it probably works the vast majority of the time, but then sometimes you need the other pair of eyes because we do things just naturally itself. You know how many times you touch your nose and your eyes and itself in a day? Those are the vectors that this virus likes to come go through. So a buddy system is very, very important itself to have. Using the proper protective equipment itself, taking care of these people, very, very important. And like in a hospital setting, it's nice to have an ante-room, a room that is a room that these people can doff their equipment and leave it there and throw it down itself. So, you know, these are things that hospitals need to look at and prepare for, is when they develop their system, how they do this process itself. And making sure you disinfect those areas. Anytime the patient's throwing up and having diarrhea, if it doesn't make it to the toilet in time, making sure you're using proper disinfections during that time and getting rid of that stuff after you've cleaned it up appropriately and making sure you disinfect yourself appropriately. The other issue I think is important is the length of your duty hours. The longer you're going to work itself, the longer that you have a chance of making a mistake itself. The CDC recommends usually if you're taking care of these Ebola patients, 6 hours is the best, what they recommend, no more than 6 hours. 8 is the max. So when you go beyond that 8 hours, you're potentially going to have more errors. You know, you think clear when you're fresh itself. And probably those 6 hours, you're probably the freshest, your mind's the clearest, you think a lot clearer itself. You know, if you're going beyond 8 hours, the day gets tiresome, you start forgetting things a lot easier. And the other issue you need to look at is the number of healthcare workers going in and out of those rooms and taking care of them. You want to bring it to the bare minimum, so you should probably be developing teams of people that should go in there itself. And this is the team that constantly will be going in there, instead of, you know, having different people going in every single different day. You want to minimize the amount of people that you have to monitor later on itself. This would help the public health side, but also you minimize the numbers that potentially could be exposed as well. And I think the other key thing is training. Training, training, and training. So you should train your groups, you should have your key groups of people that are there to be able to respond to these situations itself, and these should be your teams that you use consistently. So you should develop these key teams and keep on training on them to how to handle these highly infectious viruses or other diseases that potentially could occur. None available? Anyone like to have any questions? Yes, sir.
How were the nurses exposed to?
Well, that's the million-dollar question. Some has to happen that most likely there was some breach. I remember initially that supposedly there was some exposure around the neck where they couldn't totally cover themselves up in those first day or so. But that's the million-dollar questions. We'll never know, probably. But if you get use full protection, and probably do buddy systems and stuff like that, I think you can minimize that potential. Yes, sir.
Can you clarify, you talked about 6 hours as a recommendation for healthcare workers to work. Is that in full PPE? Is that partially in PPE? And then another few hours out of PPE working around that patient? trail lasting 6 hours?
Well, I would say to me, it's 6 hours working constantly with that. If you're working constantly, these people are not in there constantly, so they're probably going in there for X amount of hours, coming out, and then going back in. So I would say total from the time they start to the time they finish is 6 hours. So they're going to be going in and out itself. They're not going to be there 6 hours continuously itself. Yes.
The further out of the question, I think a lot of this is not about some of the nursing world, they work 12-hour shifts. Not about having a 3-hour shift where they're split up and they're coming out, they rotate out, and go into 3 hours, 12-hour shift. Oh, they're not necessarily.
My opinion, if it's a total 12-hour day, I don't think well after, 8 hours itself. I need a way of recharging itself and refocusing, itself. But, CDC you generally recommends 6 hours. So I don't know if that's a 6-hour duty day or if you can do 6 hours with that person and then do other duties itself. But it's pretty hard. Usually people I've been talking to is they want to minimize what these people do afterwards too. If it's administrative, doing paperwork, that's another thing. So.
I think I'm going to ask what I think everybody's dancing around. Are we talking about nurse-patient staffing ratio maybe for this patient is 1-on-1 or perhaps two staff person, one patient, rather than how long this person's going to be exposed? And I think that's what we're kind of doing. This is 1-to-1, 2-to-1. What nurse staff patient ratio seems to be being recommended.
Well, I don't know if there's an actual recommendation, but that's getting back to the number of people you have going in there and out of there itself. The least you have there, probably the better off you are itself. Those are probably going to be the most trained people that you have, the most experienced people itself. And that's why there's special centers like at Emory, and they're prepared for that. That's what they do. That's what they do. They train constantly for those individuals. They only have a certain team that does that work itself. They don't send anyone that, even if you have ICU training, they send specific people that are trained for that specialty itself. So that's why I think training and setting up your special teams is probably the most critical thing.
And I think you're going where I'm thinking that it's not a patient where you can assign this patient to a nurse and she's going to have a traumatic brain injury or something else. So maybe that's the answer.
Any other questions? Yes.
How long is Ebola is there, and how long is that
It could stay in the body, could stay around for a while. That's why the recommendation is burying them as soon as possible itself, or cremating them as soon as possible. Well, for days or weeks. It could be a real long time. And that's why it's critical to bury them as soon as possible, and hopefully no one's going trying to pick them up too and get them out of the bags. Yes?
Someone who has healed from Ebola and has the antibodies in 10 years can get reinfected with Ebola?
Well, all we know from the studies is they show that they still have antibodies for at least 10 years itself. Now, there is 3 different forms of the Ebola virus. I think the one that's presently circulating is the Zaire variety. But from my understanding, too, so they potentially could get infected to the other 2 variants of it itself. But the predominant one right now is Zaire form. But technically, we don't know. Only time will tell how long they have it. Now, one thing is with males, the semen can still have virus in it for up to 3 months after they're even Ebola-free itself. And that's getting back why we talking about the PCR. That's why they do cycle time. So the lower the cycle time, the more viral load they have. And that's also how they determine when they're not infectious too, and when they're free of the disease is repeating the test constantly on these individuals and looking at their cycle times. Any other questions?
On the travel restrictions, where the healthcare workers have some risk that they couldn't work, how long are they not allowed to work?
For that full, well, it's from 21 days from the day they last took care of a patient. So if they're, let's say they came, their last time in West Africa was treating a person, was a week before they left. So we would start the day, once they can prove documentation, that would be 21 days from the last time they took care of it.
So 14 days once they're back.
Yeah, that, like in that scenario, it'd probably be that way. Yes?
Are you notified by TSA or the health department that somebody from Samtec?
No, we get notified of these travelers by actually the CDC from the quarantine station. The CDC tells us because there's only X amount of airports that people from West Africa come through. I think it's around five airports. And so they get screened there, and then they inform us if they're coming back to, for me, it's if they come into the DFW region. My region's 49 counties, so it's pretty large. My region is as large as Indiana, so it gives you an idea of geographics itself that we cover. But yeah, so if they're coming in this area, then some risk, we usually meet them at the airport and try to give them their restrictions at that point in time. Any other questions? Well, thank you very much. You all have a good day.
Thank you very much, Dr. Zredek. Dr. Zredek briefly mentioned a collection of agencies that were on site at the hospital, and he mentioned OSHA being present there. Our next speaker is going to be he was the representative for OSHA on site, and that would be Stephen Boyd. Stephen Boyd is the area director for the Dallas area office of OSHA, and so please welcome Mr. Boyd.
Good morning. Thank you for having me here today. What I want to talk to you today about was not so much about the experience at Presbyterian, but it's more along the lines of common errors or common deficiencies in preparedness for infection control, including Ebola. So I'm going to talk about an exposure control plan. You have to have a plan in place in order to be prepared. And why? One, because OSHA requires it. Our bloodborne pathogen standard, 1910-1030, it requires that you have an exposure control plan for employees who have an occupational exposure to infectious materials. And also, it's to eliminate or minimize employees' exposure to those infectious materials. So when? You want to have this plan in place before you ever have an occupational exposure. And talking with some of the hospitals here around the Metroplex, talking about Ebola, a lot of the responses about we're not going to take any Ebola patients. We're not going to take. Well, that's fine if your patients come to you by appointment. You say, hey, look, I have Ebola, can I come in at 10? Most likely that's not going to happen. They're going to walk into your ER. They may answer those screening questions that the CDC recommends. They may not. If they know that they're going to be turned away, if they say yes to one of these questions, they're going to say no. They're going to want to get in there and be treated. What about that person who's non-ambulatory, who comes in incoherent? You can't ask them those screening questions. You have no idea whether or not they have Ebola or any other infectious disease. So you have to treat it as they're going to have it. You have to be prepared if they do have it. So that's when you want to have your plan in place. You want it before you ever have that exposure. And what it's going to be the minimum requirements. So this is basically what your rules are for handling these types of situations, how you're going to control any exposure to blood or other infectious materials. So, and you want it to be specific to your operation. You do not want it to be just very vague and just say, well, we're just going to cover requirements of the standard. It can't do that. You have to have it specific to your operation. What good is it if it's just general, you read it, nobody gets anything out of that program? It actually has to be a plan that you can have in place that actually applies to your workers. This plan should already be incorporated into the day-to-day practices of these workers. So, very important. So, exposure determination, all right? And something that we see all the time, I don't have anybody exposed. Everybody's in PPE. When you do your exposure determination, it has to be without regard to the use of personal protective equipment. You got to take that off the table. All right, so who's going to be actually exposed? And so you need to take a look at the job classifications where all of the employees would be exposed. And then you also need to take a look at the job classifications where some of the employees may be exposed. That's a very important work group. It's often a work group that's missed, and all of a sudden, when an outbreak happens, we're getting phone calls. With the Ebola outbreak, our number one phone call is from the receptionist, the person who's greeting that patient there at the ER. I'm left out there, I'm exposed, I'm having to handle the paperwork, I'm having to deal with these persons directly, I'm not given any type of PPE, I don't have gloves, they won't let me wear a mask, and yet I have to handle this. So you need to have a plan in place for those people as well, so you can't exclude them. When you're looking at these groups, you just don't go, A, these are all the people who have exposure to blood. B, you actually need to spell it out. What job classification? So your program should actually look longer than what the actual OSHA standard is. So you should have listed out what these occupations are that have the exposure. Then you need to take a look at what the tasks or the operations that they perform, where they would have that exposure. And this is where your plan is going to come in place, because you're then going to develop procedures as to how you're going to minimize their exposure during those tasks or those procedures. It has to be specific. So, universal precautions. That's your approach to infection control. All the time I hear, well, that's wearing your gloves and your face masks. No, that's not. It's more than that. It's actually your approach to how you're handling infectious materials. One, if you know it's infectious, you better have infection control procedures in place. If you're not sure, or if you straight out can't tell, then you better be following on the safe side and make sure that people are protected. You have engineering controls. These are controls that you can use that would actually eliminate or isolate that hazard. For an example, having a patient who has Ebola in an isolation room, so nobody else has exposure. He's not around other people. Having an anteroom where you're actually controlling who enters that area where that patient's at. So those are types of engineering controls that can be used. Work practices, minimizing the number of workers that are actually attending to that patient. Having a buddy system, as it was discussed earlier, that's a type of engineer or administrative control. Having actual procedures as to how tasks are going to be performed, which are going to minimize those employees' exposure. And one of the things that is often left out on the exposure control plans is hand washing. It is amazing. I sit there and I take a look. You've mentioned nowhere in your program about employees washing their hands. When do you need to wash your hands? Well, when you've come in contact. As soon as you remove your PPE, you need to wash your hands. But yet, it's not written in there. They say, well, we post signs saying wash your hands. All right. So I looked at a orthodontist. The way his setup was, he has multiple chairs throughout his workspace. He goes from one patient, puts on his gloves. From the very next patient, takes off a pair of gloves, puts on the next. Works on that patient. Takes off his gloves, works it. Not once washing his hands in between. Not once paying attention to how he's even taken off the gloves. So sometimes he took them off properly where he wouldn't contact the skin. Other times he's slipping his hand right through. So he's already contaminating his hands, putting on new gloves, and he's trusting that those patients are healthy. I was watching a vascular surgeon remove veins and also do sclerotherapy. Not once did he wear gloves. He came in direct contact with blood, didn't wear gloves, didn't wash his hands afterwards. He finished up, picks up his iPhone, as he was using, swipes across, ends his music that he's listening to, and walks out. Not once did he take any type of precautions to protect himself from blood. And he could sit there and say, well, we did a pre-screening at the very beginning when the patient first got. Well, that started a year ago. A lot of things can happen in that year. So, make sure that your plan addresses hand washing. Can't stress that enough. For methods of compliance, personal protective equipment. All right, so in OSHA's eyes, it's always engineer it out first, then use work practices, and then personal protective equipment is your last measure. Personal protective equipment is a burden to employees. It's a burden to you if you had to wear it. If you're sitting there for 12 hours, all decked out in Tyvek suits, multiple rubber gloves, multiple boots, multiple masks, hoods, it's going to be tired, you're going to be sweating, and the longer that you're in that equipment, the more likely that you're going to breach the protection of that equipment. You're going to want to, I got to get this mask off here just for a minute. So you're going to take that mask off, or you're going to break the seal. Or you get tired of not being able to communicate with the person working right next to you because the mask, it covers up too much of the sound. So you have to sit there and you feel like, I got to remove my mask so I can talk. Well, that's what's going to happen over a long period of time with personal protective equipment. Wearing multiple pairs of gloves, wearing all this stuff is a burden. And so you need to make sure that what you select is protected for the employees, but there's also overkill. And the more PPE that you put on, the more that you have to take off, and the more chances of contaminating yourself having to take off multiple layers of personal protective equipment. The personal protective equipment has to be provided to the employees at no cost. You can't sit there and say, well, we're going to take it out of their paycheck when they first get hired on, and that's going to cover our PPE costs throughout the year. No. It has to be provided free of charge. It has to be appropriate for the task, and you do not leave it up to the employees. When you do your evaluation of the exposures and what type of work practice controls you're going to use, what type of engineering controls that you use, this all needs to be tied in. You can't leave it up to the employees. I saw this statement that said, use the appropriate personal protective equipment when necessary. What's the appropriate personal protective equipment, and when is it necessary? That's leaving it up for the employee's interpretation as to what PPE should be worn and when they need to wear it. Don't leave it up to the employees. Hey, if you're going to be drawing blood, here's the personal protective equipment that you're going to be using. If you're attending to a patient with Ebola, here's the personal protective equipment that you're going to be wearing during that period of time. You do not deviate. This is what you wear. How can you claim employee misconduct if you leave it up to the employee and say, well, I'll let you figure it out. We have all this equipment out here. Figure out what you need, go in there, and if you wear it wrong, guess what? I'm going to reprimand you, but I'm not going to tell you what you need. Make sure that the employees know specifically what the appropriate, and you tell them when it's necessary. Make sure that they have the appropriate size and it's readily available. You've got to make sure that the PPE fits them. Like I said, it's already a burden for them to wear. Now, if it doesn't even fit them properly, one, they're going to tend to take it off sooner than they need to, or they're not going to bother putting it on at all. And training. Training is covered in OSHA's bloodborne pathogen standard, but we also have a general standard, which is 1910-132, which covers all industries within general industry. So that has its own requirements for personal protective equipment, which is a little bit more than what you'll find in the bloodborne pathogen standard. So the training, this is where you're going to tell the employees when it's necessary to wear personal protective equipment. You're going to tell them what personal protective equipment is necessary to protect them. And you're going to want coincide with the actual operation that they're performing so that they are protected at all times. How to properly don it, how to properly doff it, and how to adjust it when you're wearing it so you're not breaking the seals, you're not compromising the protection of your personal protective equipment. You want the employees to know what the limitations are. You know, you do not let your PPE have gross contamination on it and maintain your work throughout the day. You need to make sure that once it becomes saturated, you're removing it, you're washing, you're decontaminating, then you're putting new on. You're not letting the PPE be compromised. The proper care and disposal, making sure that they know how to take it off and how to actually dispose of their PPE without coming in contact with anything that could cause them infection. All right. So, before an employee can perform working with the PPE, they have to be able to demonstrate that they can put that personal protective equipment on, that they know how to take it off. So they actually have to show you that they know how to wear it. So it's not just a matter of sitting there watching your WebEx or web training and it says, well, wear a mask, wear this rubber gloves, wear this Tyvek suit. No, they actually have to be able to demonstrate to you that they know how to put that personal protective equipment on. So it's a little bit more than just saying, hey, here's your training card, here's your handout. You have to demonstrate to me that you know what you're doing when you're wearing this personal protective equipment. Because they have to actually understand how this personal protective equipment is going to protect them. They have to demonstrate their ability to use it. So you're going to have to watch them, making sure that, you know, if something becomes contaminated, they're removing it. If they're wearing a respirator, they're actually wearing it properly. Not just one strapping like a lot of people will do, to make sure that they have it on properly. And they need to retrain. So if you see somebody not doing what they're supposed to, you need to retrain them. If the workplace changes or if your practices change, your exposure control plan should be a living document. Shouldn't be when I come in, you're blowing the dust off it, you're taking your coffee mug off it, and then trying to peel the pages where the coffee ran through and caused them to stick together. It needs to be a living document. You need to update it. You need to review it. Get your employees involved. They're the ones who are doing these operations day to day. So in order for it to be an effective program, they need to be involved with developing those procedures. So very important that you keep your program up to date. It shouldn't be something that's left up on the shelf and you wait for OSHA to show up to show you. Because that's not doing me any good, and it's not doing your employees any good. Housekeeping. A lot of times, these are the two paragraphs in the OSHA standard which talks about housekeeping. And it's fine as far as a general requirement, but as I look through exposure control plans, it never mentions how you're going to clean. It says, well, you're going to clean off the equipment. All right, so what am I going to use? You have specific disinfectant. You have disinfectant specific for equipment versus the countertops versus the floors. It needs to be specified in your plan as to how you expect these employees to clean. Are you going to be spraying the spill directly with a spray bottle, or are you going to be putting it on a rag or a cloth that you're going to wipe, or are you going to pat it? What are you going to do to minimize the possible exposure and spreading of that material? So those types of things need to be addressed in your plan, and from most of the plans I see, it's not even mentioned. Or if it is, it's no more than what you see on the slide. So what you need to do at the time of the employee's initial assignment, they need to be trained on your exposure control plan. It needs to be at least annually thereafter. And also, if you have changes in your work procedures, if you have new tasks, as engineering controls become available or new procedures come available, make sure that your employees are kept up to date and make sure that they're trained on your program. And I also threw in respirators. Respirators throws in its own standard. It has 1910-134. It has its own requirements. So you can just not, or you just can't go and give an employee a respirator without anything additional. So You have to have your own written respiratory protection program. You're going to talk about how you're going to select the respirators that the employees are going to be using. You're going to talk about how the employees are going to be trained on those respirators, how the medical evaluations are going to be performed, the fit testing that you're going to be using for these employees. That's all going to be spelled out in your respiratory protection plan. Employees, before you are allowed to require an employee to wear a respirator, they have to be medically evaluated. Again, wearing a respirator is a burden to the body. If you have some type of respiratory problem, it could be aggravated by wearing a respirator. So it's important that you are medically evaluated and that you're capable of wearing that respirator. Fit testing. If you are wearing a tight-fitting respirator, you have to be fit tested. So if you are wearing a PAPR with a shroud that's loose-fitting, it's not actually touching your face, you don't have to be fit tested for those. Those N95 masks that are being used, you would have to actually be fit tested for those respirators. And those are respirators, they're not masks, they're not nuisance dust masks, they're actual respirators. You do need to be fit tested. And then again, employees have to be trained. They have to be able to demonstrate that they know how to use that respirator, how to don it, how to check the fit to make sure that it's fitting them properly. You need to be able to have them demonstrate before they ever wear this that they're capable of wearing it properly. So, that's my presentation to you. And again, I just wanted to focus on the areas that I see problems with when I evaluate exposure control plans. And I ask you, when you go back to your facility and you start looking at your plan, see if any of the things that I've talked about are in there or are missing. So it's a challenge because more than likely when you see this, you're going to be thinking, gosh, he was talking about my plan. Because I see it all the time. Yes, ma'am.
So when we're talking about N95s, are you saying that they have to have N95?
Well, what happens is the OSHA standard has a questionnaire at the back, an employee questionnaire. So they're going to fill that out. Then the doctor's going to make the determination. He could look at that and say, okay, I'm not going to need to see them and sign it. Or more than likely, he's going to want to see that patient. He's going to want to talk to them, and he's going to want to find out exactly what task that they're doing while wearing that respirator before he signs it off. So, but you have to have at least that employee questionnaire completed and signed by a physician. Yes, sir.
Steve, one question about training. You don't think we need, besides to over packaging, we need another training like Hasselhoff, for example, to learn very well to use it as PCAs and all these kind of things. More quickly, guys, we don't have right now a material, real specific material for this type of training, and that's only about packaging. It's kind of generic, very generic. We need something more specific for these guys working in the healthcare centers. They need to be really clear of what kind of training, how they're going to use it. Maybe firefighters, all police, they have that training, but not everybody else.
Right.
So I was thinking yesterday, half worker, the 40-hour half worker, why don't we get something this training over here so they can know, touch it. For example, how they can build a decom area.
Mm-hmm.
What is decom? I don't know.
Right. And these types of things need to be addressed in the plan and part of the training. And like I said, with the PPE, it does need to be more hands-on. So you just can't sit there and show a PowerPoint and then say, okay, that's all your training, because they actually have to demonstrate. So if you're going to run through people, have them sit through a classroom, and then they're going to go don it, and they're going to show you how they're going to wear it throughout the day. That's more along the lines of what they need to do. It's just not, hey, here's a respirator, go use it. Hey, here's some rubber gloves, go use them. You know how to do it already. I don't need to show you. That's not what it's supposed to be. Yes, sir. No, there's no set amount of time, but it's going to come back to when the employees, when you're checking their ability to demonstrate and their knowledge of the PPE, if they can't tell you what the protection factor is or what that specific type of PPE is even used for, you need to spend a little bit more time with the employees. So there's no set amount of time. Some people are going to catch it on quicker than others. So we don't have a time frame set for those.
Can an ER actually turn a patient away?
That's not a no-show. I don't have any jurisdiction over something like that. But, so I don't want to answer that question. I'm sorry. Okay. Thank you.
Didn't mean to purposely try to cut off any of the questions, but for time management purposes, what we'd like to do is save the questions for when the panel comes up towards the end, and that we have enough questions for them to answer, and to provide ample amount of time for the speakers coming up. So I appreciate that. Thank you. Next, we have Chris Brown. Chris Brown is from the OSHA National Office. He is, as you can see, with the Office of Emergency Management Preparedness. So without further delay, please welcome Mr. Chris Brown.
Right, good morning. So yeah, I'm from OSHA's National Office in Washington, D.C. I'm in the Office of Emergency Management, and our division was charged with coordinating the national preparedness and response efforts when the Ebola outbreak started in West Africa over the summer, and then when we first started seeing domestic cases here. So I'm going to really focus kind of on what OSHA. There we go. All right, so I'm going to focus a little bit on the Ebola cases elsewhere outside of Region 6, and then talk about OSHA's response efforts. And I'm also going to try to give you some context on what was going on in the rest of the federal government. I know that the aim with this symposium was to try to get someone from CDC to come and talk, and they were unavailable. So I'm going to try and cover a little bit of the information that they likely would have presented. And we've been coordinating very closely with them, so I should be able to give you a good bit of background on that as well. All right. So I won't, spend too much time on this, but this is just kind of an update on what the latest worldwide case counts are. We've seen more than 22,000 total cases, with about 14,000 of those laboratory confirmed, and approaching 10,000 deaths. And this was as of just a couple of days ago on March 6th. And like we already discussed in some of the previous presentations, 4 of those were in the U.S., 1 death, and all 4 of the U.S. cases were lab confirmed. So 3 of the cases, obviously, as you all will know, were here in Texas, in the Dallas area, and then the 4th case was in New York City. This was in late October. New York City Department of Mental Health and Hygiene had a case there that they confirmed. It was a doctor who had been volunteering with Doctors Without Borders and came back from Africa. He eventually recovered and was discharged in early November. So OSHA stood up its federal response efforts starting in July of 2014, and that's when we first started getting visibility on these cases that were popping up in Africa. We started having clusters of outbreaks in several of the countries in West Africa, and that's what eventually flared up into this major outbreak, which is the largest that we've seen as far as an Ebola outbreak goes. OSHA began trying to ramp up our efforts to provide technical support and assistance, not only to other federal agencies, but also to state, local, tribal, territorial governments in their preparedness efforts, as well as ramping up our outreach efforts to private sector stakeholders in states where federal OSHA has jurisdiction, and making sure that we were providing resources to support our state plans in states where state plan programs have jurisdiction over occupational safety and health. Throughout that whole time, we were coordinating very closely with CDC and NIOSH to make sure that we were adequately addressing worker safety and health issues, both from our perspective as a regulatory and enforcement agency, and their perspective more as a public health entity within CDC. OSHA's Office of Emergency Management and Preparedness had devoted, at one point, we had about 4 staff people working full-time on the OSHA issue. We brought in some additional assistance from our Salt Lake Technical Center. So someone with some biological agent expertise came in to kind of help us out with development of guidance products. And we were working pretty much solely on the Ebola issue from about the end of July, early August, up until just a few months ago. And I can honestly say that there were months in there where I did nothing but Ebola every single day. So we were very busy and focused on that. Glad to be doing something else for a little while. I want to give you a little bit of background on how the federal government response was going, and then kind of contextualize what OSHA was working on within that response. So CDC was the overall lead, and that kind of came out of a decision from the White House in DC that CDC would take the lead role, and all the other agencies who had stakes or pieces in the effort would kind of work through this framework that was set up. CDC's Emergency Operations Center has been going for more than 240 days, and I think we're almost at 250 days, and they have about 300 staff members, both domestically and abroad, who are CDC staff, members of the U.S. Public Health Service, which is under HHS, working on different types of, whether it's epidemiological monitoring or laboratory support missions, a whole variety of tasks. And like I said, besides OSHA and CDC, there have been plenty of other federal agencies involved in the response and preparedness effort. The Department of Homeland Security was tasked with screening travelers who are coming into the U.S. from abroad, doing symptom checking as far as temperatures go, looking for fever in travelers coming back, as well as evaluating them for other risk factors, whether or not they had had contact with someone who was sick, had attended or been part of the funeral of someone who had died of Ebola or suspected Ebola, where the person has been, among other risk factors. And all of those individuals were funneled through 5 major airports. So when the Department of Homeland Security first started looking at the possibility of implementing travel restrictions, they took a look at where all of the air travelers were coming into the U.S. from West Africa, and figured out that about 95% of travelers were already coming into the 5 airports. So Atlanta, JFK, Newark, Washington, Dulles, and Chicago O'Hare. So it was pretty easy to say to the airlines, okay, you've got to route all of your people coming in, all of your passengers coming in to the U.S. from West Africa through these 5 airports. So it really only took an effort of moving about 5% of West African passengers' tickets to those 5 designated airports where they set up screening points. The Department of Defense was deployed to West Africa to provide support over there. They were helping with building Ebola treatment centers and setting up lab facilities, although they weren't doing any direct patient care themselves. The Department of Transportation was involved in a couple of different ways. Primarily, the FAA was working on making sure that there were sufficient guidance out there for protecting the health and safety of flight crews who were transiting back and forth, not only between the U.S. and West Africa, but who also might encounter patients who had connected through other airports. So a lot of travelers who were leaving West Africa would fly through Frankfurt or Brussels and then connect to a flight on a U.S. carrier. And we wanted to make sure that flight crews were prepared in that respect. So OSHA worked a lot with FAA on that. Another entity within DOT that I don't have on the slide is the Pipeline and Hazard Materials Safety Administration. And they were responsible for kind of coordinating waste issues as far as Ebola-contaminated waste transport goes. The EPA was also involved in waste handling issues since they have some authority over incinerator facilities. They issue guidance on autoclaving and sterilizing and use of disinfectants. The National Institutes of Health, in which the National Institute for Environmental Health and Safety is, also did a lot with training, developing guidance for treatment of patients at NIH, and then obviously the NIH Clinical Center was handling a number of patients who were repatriated. Some medical aid workers who were brought back from Africa were sent to NIH for treatment. And then many others beyond those mentioned. I'm not going to spend time on all of those. What I really want to focus on is workers that are at risk for Ebola virus, and talk about what OSHA was doing to make sure that those workers were protected. So there's a whole host of workers in a variety of industries, and I've listed some of them here. We've kind of split this up between healthcare and non-healthcare because the types of hazards that are faced in healthcare industries versus non-healthcare industries are very different. In healthcare, there's a whole gamut of different types of exposures and different levels of risk and exposures that workers might have. And there's a similar range of exposures in non-healthcare settings, but obviously, it's very different from the direct patient care, hands-on interacting with individuals who are either suspected of or known to have Ebola, and that's not necessarily what's always happening in non-healthcare settings. Outside of healthcare, individuals who are involved in death care, who are obviously, as I mentioned before, airline workers, workers in other types of transportation operations where you're dealing with members of the public, bus drivers, subway operators, individuals involved in waste handling, transport, treatment, disposal, individuals who are doing customs and border screening and screening of travelers in and out of airports and seaports, and as well as cargo in and out of airports and seaports, and other types of law enforcement personnel who have close interaction with members of the public may also be at risk. So in healthcare, there's a whole variety of things that could lead to exposure. Evaluation of patients in the emergency department, performing any types of medical procedures that generate aerosols tend to be especially hazardous because not only are you worried about contact exposure, but also about exposure to bioaerosols that may contain droplets of Ebola virus particles. Workers who are involved in cleaning and decontamination of equipment, of patient rooms, of beds, of the air handling systems in isolation rooms, and then workers who are handling waste, all the way from the point of generation in a patient care room, or from a lab, or from another task in a hospital, up until the point where it's either incinerated or sent to a landfill after it's otherwise been treated. In laboratories, we have workers who are doing all sorts of things, ranging from the typical handling of specimens when they come into the laboratory to actually opening the tubes, mixing them with various reagents, doing vortexing, where they're basically spinning tubes, and that can lead to generation of aerosols, and a number of other procedures that can result in splashes or sprays if they're not carried out properly or in proper containment. In addition, in laboratories, one hazard is also that workers who aren't necessarily working with Ebola samples from an Ebola patient or a potential Ebola patient themselves, some of the types of lab procedures can result in workers in the nearby area also being exposed just because of the types of tasks they're doing and how that may aerosolize Ebola particles in the lab air. OSHA also had been focusing a lot on workers in the waste handling industry. Workers who are doing everything, like I mentioned before, from collection of waste where it's generated all the way through transporting it, treating it either on site in a hospital or other type of facility, or in a central facility where lots of waste is transported to, and then commercial operation where they actually treat the waste, and then in the end, disposing of waste that's already been treated. That's not a hazard, and that was one thing that we were struggling with, along with some other federal and state partners, in trying to convey that message. But these other types of tasks that I mentioned up front, we had to come up with some guidance for and try to figure out how to help employers protect their workers doing those types of things. And finally, workers in the transportation sector were the other major group that I wanted to give you a little bit of an idea about exposure there. Like I mentioned with air crews and individuals who are working on border screening and screening of passengers moving in and out of U.S. airports, you're interacting with travelers and passengers, many of whom either have come from West Africa or may have been on flights with others from West Africa or had some sort of other exposure of various risks. Individuals who are handling potentially contaminated cargo, as well as people who are cleaning transportation vehicles and facilities. So that's everything from typical janitor in the airport who may not typically have very much exposure to somebody who is cleaning out the restrooms on an airplane and emptying the sanitary tanks once a plane comes in from wherever its origin point was. So when all of the Ebola stuff started, there was great concern from a number of worker groups saying, oh no, what do we do? There's not already information out here about this. OSHA doesn't have any standards to protect workers from Ebola, and that's not the case. OSHA has existing standards that are directly applicable to Ebola and other infectious diseases that definitely apply here. First and foremost is the bloodborne pathogen standard that Steve was talking a lot about. And the bloodborne pathogen standard itself actually mentions Ebola and other hemorrhagic fevers directly, so that is covered. We also have, obviously, our personal protective equipment standards, the general standard, face and eye protection, hand protection standard, respiratory protection, and all of those are applicable to biological exposures, exposure to Ebola virus in particular here, as well as a number of other standards that kind of come in and play supporting roles in protecting workers. Our hazard communication standard applies to chemical exposures, so anytime a worker might be using cleaning or disinfection chemicals, the employer has responsibilities to protect the worker there. And then the employer is also required to comply with OSHA's standards on access to medical records, record keeping, and then kind of our overarching umbrella clause here is the general duty clause of the OSHA Act. So when an employer has a recognized health and safety hazard, they're obviously required to abate that hazard and protect their workers there. So as I mentioned, OSHA's bloodborne pathogen standard covers any pathogen that's bloodborne, including viral hemorrhagic fevers like Ebola. And the bloodborne pathogen standard applies to any reasonably anticipated contact with blood or other potentially infectious materials, and it's pretty clearly defined in the standard what that means. So that's any body fluids such as semen, vaginal secretions, body fluids that are contaminated with blood, and any time where you really can't tell what the fluid is, or you can't differentiate between whether it's blood or something that wouldn't otherwise be covered, OPIM applies, and thus bloodborne pathogen does. So as Steve mentioned, he kind of went through all of these in more detail, so I'm not going to spend a ton of time on this particular slide. But the bloodborne pathogen standard has requirements for exposure assessment, for developing a control plan, for integrating your workers into development of that control plan, for making sure that you're providing PPE, and importantly, training your workers on how to use it, how to put it on, how to take it off, how to keep themselves safe while they are wearing it, and making sure that employers keep certain types of records for training, exposure, medical evaluations. So during the outbreak, OSHA spent a significant amount of time coordinating our efforts with other federal partners as well as state and local partners, doing lots of outreach to other types of stakeholders, whether it's private sector, companies, work groups who represented workers, labor unions, groups who represented employers, like trade associations, developing technical support and guidance materials that were available to all those types of groups, and then providing technical assistance in the field, like going out to hospitals and helping make sure that they were prepared. I'll talk a little bit more about that particular thing at the end. So on the lines of federal interagency coordination, as I mentioned at the start, OSHA was coordinating very, very closely with CDC and NIOSH throughout this whole outbreak and throughout our whole ramp up and development of our guidance products. Basically, when OSHA would develop something, we would make sure to vet it through CDC and NIOSH to make sure that not only were we putting out accurate information, but also that it was in line with what they were saying. We made a very concerted effort to make sure that anything that was coming out of CDC matched what OSHA was saying, so that employers didn't say, okay, I've got guidance from CDC here, but it says to do something different than what OSHA is saying. We wanted employers to easily be able to comply with the OSHA standards and follow OSHA's guidance, while at the same time being in line with what CDC was recommending that they do. We worked very closely with the White House Office of Science and Technology Policy on PPE issues. At the beginning of the outbreak, there were questions about what types of PPE would be adequate for protecting workers from Ebola, as well as about dealing with PPE supply issues. So the Strategic National Stockpile folks were involved, and the White House OSTP office was involved, just trying to make sure that we were not recommending PPE that either A, workers couldn't get, or B, wasn't sufficiently protective. We kind of wanted to factor in all of those issues in our recommendations for PPE. HHS and their component agencies were also involved in development of training that was then delivered to workers. I know that they've done some programs at airports, particularly up in Region 2 at JFK and Newark, in training workers who were doing things like baggage handling and cleaning of airplanes, general ground crew work on what to do in instances where they might encounter potential Ebola hazards or exposures. OSHA worked very closely in a group that was covering waste handling issues, and that was an OSHA-led initiative. But we had participation from EPA and DOT. We held meetings with stakeholders in the industry as well as with worker groups, and tried to kind of glean some best practices, what types of tasks were going on in the waste handling industry, where were the gaps in guidance, and answer questions for them so that they could adequately protect their workers who were doing many different types of tasks all along the waste stream. I talked a little bit about PPE already, so we'll skip over that for time's sake. We also worked very closely with the Department of Homeland Security. So when they started doing screening efforts at the airports, DHS came to OSHA and wanted to make sure that what they were implementing for their workers, and they were using, for instance, Coast Guard, medical corpsmen, and employees from Customs and Border Protection to do these screenings. They wanted to make sure that their protocols, especially for PPE for their workers, were sufficient to keep their workers safe. So for DHS, as well as for VA, the second point on the slide, we've worked very closely with them to kind of review their health and safety plans with respect to Ebola and make sure that they're both in line with what's required by OSHA, federal employers, as well as doing what they need to do generally to keep their workers healthy. We've also been involved with several initiatives within the Institute of Medicine, particularly related to PPE, as well as with the FAA and CDC NIOSH in work groups with airline stakeholders, like I mentioned before, on keeping those workers healthy and safe. We've been providing a lot of technical assistance regarding PPE, general infection control, methods for isolation in an atypical aircraft environment, in those types of work groups with FAA. On the state coordination and outreach out front, we've been doing as much technical assistance as possible from the regional and area office levels, as well as from the national office level, to try to provide state agencies with the information that they need. And we've been doing that both for states where federal OSHA has jurisdiction, and we're working with the state emergency management agencies or state departments of health, as well as in the state plan states where state OSHA has jurisdiction and federal OSHA is providing technical support to the state, and then the state in turn to their other state agency partners. We've done a lot of guidance document reviews. In one instance, the state of Rhode Island put out a number of checklists to help their hospitals get prepared, and we offered some assistance there to make sure that their documents were in line with what federal OSHA was saying hospitals needed to be doing. We also developed an internal kind of Wikipedia-style page called OSHApedia, and all of our federal OSHA offices have access to this, as well as any of the consultation programs and the OSHA state plan states. So it's kind of an user-editable repository of information where we were able to put documents. Our compliance staff out in the field can go to this page and kind of get background on what the issues are, what OSHA has done to date, what the available guidance is, standards that apply, all the things that they might need to know before they go out and do either a compliance inspection and investigation in the field, or something more informal where they're just trying to offer compliance assistance and help a hospital get prepared in the event that they have a future Ebola patient. Some other types of outreach that we've been doing on the public front, we've been fielding lots and lots of questions, covering everything from, I'm worried that I might have exposure on the job. Do I? What do I do? Other things coming in from employers about what sorts of PPE do they need? Should they be stockpiling PPE? What types of disinfectants should they have in their workplace? All sorts of things like that. We've also been heavily involved with maintaining contact with both labor unions and representatives from the trade groups. So during the peak of the outbreak, we were maintaining weekly calls with different labor groups and different industry groups and making sure that we were addressing their questions. It was also very helpful internally to OSHA because we were getting better visibility on these industries. Obviously we're charged with oversight over lots of different types of workplaces, so it's difficult to know exactly what processes go on in all these workplaces, and having these types of calls gave us some good insight on what types of things are their workers doing on a daily basis, where are the information gaps, and how can we help address them. Our biggest outreach, I think, right at the start of the outbreak, and we were out there with this before domestic cases started popping up in the U.S., was OSHA's Ebola webpage. This has had more than 100,000 visits since it was posted in early August. I think one day in October, when the cases were going on here, we had 13,000 visits on this particular page, and it's basically a central access point for everything that's related not only to Ebola but also to bloodborne pathogens, PPE as it applies to Ebola and bloodborne pathogens, the other OSHA standards and other OSHA compliance assistance and guidance materials. So you can go to this and download anything that we've got available that would relate here. We also produced a number of fact sheets. The first one is a cleaning and decontamination of Ebola on surfaces. And this fact sheet was meant to apply specifically outside of healthcare settings, outside of labs. So we were trying to address cleaning in all the other situations where, for instance, contract employers would come in and clean an apartment, or janitorial workers are cleaning up spills and splashes in airports or other types of businesses. But the recommendations that are in this fact sheet are fairly applicable in those healthcare and lab settings as well. It was just kind of meant to fill a void where CDC had already really fairly well covered hospital and lab employers. The other fact sheet that we produced, and this is what I mentioned earlier, was done jointly with NIOSH and EPA, was a fact sheet on safe handling, treatment, transport, and disposal of Ebola-contaminated waste. So this particular fact sheet covers everything from point of origin, methods for generating less waste in the first place, considerations for how you might store and treat the waste on site before you send it off for treatment, as well as what types of things can be done in large commercial facilities that handle waste. So safer work practices, engineering controls, elimination and substitution in those types of facilities to keep workers safe there. And then it also provides some information on the ultimate disposal of waste. So what you might need to do with waste that's either incinerator ash or products that still look like medical waste, but they've come out of an autoclave, so they should be considered sterile, and how to operate those autoclaves safely. Our last guidance document here that was an interagency document was the OSHA NIOSH fatigue guidance. We talked a little bit about fatigue in a couple of the previous presentations. So this really covers methods for rotating workers in and out, how to assess workers who may be using PPE that add extra fatigue and lessen the time that they can work, considerations for dexterity when workers are working in PPE, all sorts of things along those lines. And finally, probably our most in-demand guidance product during the outbreak itself was the PPE selection matrix. I know we have copies of those today if you want one. This matrix is basically OSHA's effort to take the complex issue of PPE and turn it into task-based guidance, where employers could look at the matrix and say, okay, it's not about what industry I'm in or what job title my workers have. This allows you to go across the top of the matrix and say, okay, in this instance, I have workers doing task X. So I need to put them in the PPE that's listed down the side. And the good thing about the matrix, and what we thought was one of the most useful features of it, is that it provides a number of different options. So not only can employers move their workers from one column to the next as their work tasks change throughout a work shift or the work day, but they also have different options down the rows for different types of PPE. So for instance, in the respiratory protection section, you can see where several boxes are kind of shaded all in together. So employers have the option of using different types of respiratory protection that OSHA, in conjunction with CDC, determined should be equally protective in those types of instances where we made those recommendations. The front and back of the fact sheet gives some good context on why workers need PPE, how workers should be trained in using it, putting it on, taking it off, and then the back really goes into detail on what the nuances of selecting PPE might be, especially in healthcare and in labs where it tends to get complicated based on the exposure or the hazard present. Finally, I just wanted to touch on OSHA's hospital preparedness efforts, and this has really been an effort that has involved all levels of OSHA, from the national office down to the regional office and the field office in the areas. So OSHA staff was going out to the 35 hospitals that CDC a couple of months ago designated as Ebola treatment centers. Those were our highest priority, and in some instances we were participating jointly with CDC teams who were going into the hospitals and doing preparedness initiatives where they were looking at the procedures that the hospitals had put in place, not only for patient care but also for worker safety and health. And we were looking at their PPE stockpiles and what types of PPE they had selected and purchased for their employees, how they were doing employee training. We also are making an effort, and this is still ongoing, in a number of the regions to visit Ebola assessment hospitals. So these are hospitals that are designed to be able to handle an Ebola patient, do a diagnosis, stabilize the patient, and then send them to an Ebola treatment hospital where their 2 to 3 week course of treatment may last. But they're supposed to be able to keep them there for a couple of days and safely treat them while they're there. Like I mentioned, our focus during the hospital visits was really technical support and assistance. We're really not doing enforcement, or we weren't at least. As the outbreak goes on and begins to settle down, we'll transition back to enforcement where employers are obviously required to comply with OSHA standards. But our big focus here was making sure that employers had the information that they needed to be able to either develop a plan or update their existing plans to be suitable for OSHA and protect their workers adequately. So I'm not going to take any questions right now in the interest of time, but happy to do so when we have the panel discussion at the end of today.
Where is the PPE matrix available?
It's available right there on that table, or you can get it at osha.gov/Ebola. Thanks.
Thank you, Chris. Just as a reminder, these tables you see down front, there's also a table up out that top door to the left or to your right. There's publications out there, publications from UTA, from OSHA, and from Dallas County. So with that, why don't we break until about 11 o'clock and give everybody a chance to kind of stretch their legs a little bit. Thank you. All right, welcome back, everybody. Our next presenter comes to us from the Dallas County Health and Human Services, and we have with us today Director Zachary Thompson and Assistant Director Tamara Scroggins. Welcome, Mr. Thompson.
Please.
Good morning. Thank you for the opportunity to talk about a subject that hit Dallas County, the state of Texas, and the nation, the Ebola crisis. Tamara Scroggins, who is our Assistant Director for Public Health, Erica Nero, who is our Public Information Officer, and I see Julie from Dallas County Health and Human Services. This was an all hands on deck. And before I get started, I want to thank all of the state partners, OSHA, our local health directors that are here today, because this was definitely a team effort in responding to the first Ebola case in the United States. Let's talk about timelines. For those who play golf, if you get a do-over, you will want this to be a do-over, that this situation would have never happened. And so the first step is going to be the key point, and while I may not list out lessons learned, I got to be very clear that hospital readiness has to be on the top of the agenda as it relates to funding. We can't just keep talking about the Ebola crisis, and I find it amazing now that everybody wants to be heroes of the Ebola crisis, but that's a different shift. We should be focused on the fact that how we're going to generate funding or direct funding to hospital readiness and to local health departments to be prepared for emerging diseases that we see throughout Dallas County, throughout Texas, and throughout the nation. And as we began to look at this, if you see that in July of 28, we talked about a health advisory going out to the Dallas County medical community, letting our medical community know that there would be a possibility of a case in the United States and could be locally. We talk about from that point on in terms of dishes, and I'd like to thank Dr. Zaretic personally, and I want to thank Dr. Lakey for their being on the ground day one and involved in this response. And I'm going to talk about a lot of misinformation that is out there as we go through, because I hear a lot of people talking about what went wrong, and so we need to kind of put some things in perspective in terms of this whole Ebola response. You talk about the quarantine public health officer notified in terms of local health department officials, August 27th. We talked about updating our plan in terms of how we deal with screening of patients. But again, we talk about September 29th. If you look at September 28th is when Mr. Duncan was in the hospital. But on September 29th, we were notified. Dr. Perkins, our top doc, and myself were notified about a possible Ebola case in Dallas County. And at that point, contact tracing and contact investigation was already begun. The situation that I hear a lot of times as I'm traveling, and especially if I travel down 35 to Austin, I find it amazing that those who are talking about what went wrong were not here in Dallas on the particular date of September 29th. So as we move forward in this process, we have to be very clear that on September 29th and then on September 30th, we were given an update to the Dallas County Commissioner's Court. Dr. Perkins, you'll see later, I gave an interview that same day, but this case was confirmed. At that point, CDC was already en route. Dishes was already on the ground. So you had your teams in place. Everyone was doing what they needed to do. And so if you look at this timeline, it was very fluid in terms of what happened, when it happened, in the time frame that was given as it relates to the first human case in the United States. Now, of course, there are some things that needed to be addressed, and we'll talk about that in this presentation. But the key point, all of the key players, CDC, DSHS, local health departments, had basically got in position to begin to respond to the first Ebola case in the United States. Won't go into the clinical aspect, but we spent a lot of time in terms of the top doc, Dr. Perkins, our medical director, health authority, reassuring the Dallas community of the fact that this situation was contained and that we were doing the contact investigation. At that point, we got to be very clear. There was a lot of unknowns. You didn't know how far out the contacts in terms of the hospital contacts, in terms of community contacts. I don't know if any of y'all are familiar with the apartment complex where Mr. Duncan lived, but that is a resettlement population where a lot of the refugees that resettled into Dallas County live in that Victory Meadows apartment area. So you have various languages that are spoken in that area. And so it's the key point was dealing with contact tracing, monitoring, public health follow-up, and again, focused on all contacts remain asymptomatic at that time. The scenario here was Dr. Perkins was asked to go and do a assessment of Louise, Mr. Duncan's girlfriend. Louise is Mr. Duncan, Louise told, and part of that, we did the control orders the night before. This photo, you never know who's taking a picture of it, so we didn't know to turn to smile. But the concept is that when we came out of that, Dr. Perkins basically had done a physical assessment. Now, you got to remember, all public health is local. So whatever you're hearing down in Austin, I find it amazing that the top doc, who is the local health authority, medical director, was on the ground. And so when you look at it, when you focus on that, you got to look at the fact that the control orders were delivered with, we consulted with DSHS, Dr. Lakey and their staff in terms of issuing a control order. And I stand very clear, and I made my position then, I'm still in that position now. If we're going to issue a control order to Mr. Duncan's family, to Louise, then everyone should have been under some type of control order at that point, and that includes the hospital workers as well. And so as we looked at the interim guidance that were developed from the CDC, we see that those things were moving pretty fluent. And I'm going to turn it over to Tamara Scroggins. I'll talk about our top doc. Here's our top nurse, so I'll turn it over to her.
So as we look at clinical and coordination, again, as Dr. Thompson alluded to, we coordinated with our local, our Austin authorities, our local authorities, as well as I see we have our local emergency management in the audience here, as well as our hospital preparedness, in order to look at clinical aspects. And again, the key in clinical aspects and the key for public health and what's one of our 10 essentials of public health is, of course, education. And so when we move into the clinical aspect and being transparent, we here at Dallas County, DCHHS, we were definitely providing education, providing that clinical aspect of education, and we were definitely being transparent in the information that we received and disseminating that information out. And so here is, of course, a different timeline of the case and the contacts and the number of contacts that we investigated, as well as the ongoing monitoring that we're continuing to do with travelers coming into our location. We participated in ongoing communication and education efforts, CDC, DSHS with our EOC, again with the boots on the ground with those local emergency managers as well as those hospital emergency managers. And we continue with the investigation and the monitoring and the constant education. Again, because I'm a nurse and I have that nursing background, education is very key. You definitely want to ensure that you provide that education, you provide that transparency to your community so that you can somewhat calm the fears, especially when you're dealing with the media who's out there and they're hiding it and they're taking pictures and they're taking conversations and they're turning that conversation and those that information into different avenues. So we responded to more than 300 resources, over more than 500 emails, calls day to day. Again, when we talk about heroes, staff that were not necessarily on the ground, that were not necessarily management or local health authorities, they did everything and all means possible to gather information, stuff packets, get packets ready, education ready for those town hall meetings we went to, those school meetings we educated, those communities we had to educate. Again, here, communication, our website, 1,000-page views. We had Facebook, Twitter feeding. We even opened up our call center operation where we received numerous amount of calls, and we got education out the best way that we could. Communication, again, when Director Thompson too alluded to miscommunication and misinterpretation of what happened on the ground. DCHHS, Dallas ISD, the Dallas Schools ISD, we were the first to get language translated into, and the information translated into, more than 11 different languages. We knew the need, especially from that community, the need to get that education out and ensure that we provided the most means of communication as possible. So again, I commend our public health information officer who worked diligently, throughout that time to get those flyers and that education translated into several different languages. Again, we see the communication, as I alluded to, the text messages, the emails. Again, I want to send my respects out to Dallas Medical Society, who partner with us to provide and answer those emails and medical questions as we receive them. And again, outreach. There were not only just those who were in local management areas or authority areas, there were other members on the ground. Again, MRC, I want to conduct my respects and thanks to VOAD, to those charity organizations who helped and who called and who volunteered to, whether it was to stuff packets, provide education, and or go door to door to provide those educational documents. And again, to the local management, to Dallas EOC local management who went door to door as well to provide that education.
As Tamara pointed out, a lot of key staff and a lot of volunteers, medical reserve staff was involved in that. I want to go back to one thing. I don't know if any of y'all ever been to the M Street. Those blocks are very long. So to deliver material, you need to be in shape when you go and drop off material. We did a number of press conferences. Of course, Dr. Zredek has joined us at that particular press conference, elected officials, mayors, as well as school superintendents. We were at Presbyterian. Again, as Tamara pointed out, this is a small list of everyone who was involved in the response effort, and all of these groups are heroes in terms of what they had to deal with. I can't say enough about Wilshire Baptist Church. That's the church that Louise attends. Louise told. The fact that you have a church who basically provided support not only spiritually but financially. The rest of the story, as Paul Harvey used to say, is that when she left out of the quarantine or the control orders, no one wanted to rent an apartment to her. And so it was this church that stepped up to ensure that she had somewhere to go with her family. So we can't say enough about those individuals who are the real heroes. Again, we're talking about, and I see Candy and Matt here, I won't go too much into the legislative details. We may disagree on a couple of these, but my concept is that we believe that there has to be some legislative changes. I think Vinny, in terms of Tarrant County, we all agree that something has to be done in terms of communication. One of the stories we have to revisit on the control orders is that when we talk about law enforcement being involved in the process, they have to have the appropriate information and the appropriate PPE to go into these situations. Now, we may disagree on the legislative language of how this should be done, but I think we can agree that we have to work out a communication factor to ensure that law enforcement is on the same page with public health as we go into an area that could possibly infect them. So while it may be a tough bill in terms of Senate Bill 538. I think we can all agree that there has to be some revisit on that particular bill to make it a win-win, because I do believe our first responders do need to have the appropriate information when they go into a apartment or house. We want to thank CDC and dishes, additional funding, of course, never enough, so we do need more. And so in that process, Erica put together a newsletter that, to me, and we have copies here, that outline the response effort. There are stories that will be told, but the real story is about Mr. Duncan arriving at a hospital the first time. The real story is that Mr. Duncan went back to the hospital a second time. And the story is that from that standpoint, the community was impacted. The apartment owner, who was held hostage by the national media, who wanted to say things wasn't going right. From the moment of the diagnosis, the confirmation on that Tuesday, to the fact that they were moving out on that Friday or that Saturday, that was pretty swift. Because at the end of the day, where could you move that family? No one wanted the family in their neighborhood. And the fact that there was a mission, a church who set up a cottage area to let them be housed there. You had Red Cross, you had so many people delivering meals to them. These are the real stories. We had disease detection, we hear that in terms of going out, but at the end of the day, there were people delivering meals, people taking items that were needed. And so these are the real heroes that you won't hear anything about. But hopefully this is a once in a lifetime experience, at least for Dallas County. You can have it really next time. I'm in Tarrant County now, yeah. But the concept is that we use this as a model going forward of how to improve our local health department, our hospital readiness, our state and federal response aspect. But I clearly knew when I went in that apartment that night that no one was going to be infected coming out of this area with Ebola because of what I saw in terms of what had been done. The real issue was at the hospital. Not to say that that wasn't a situation where they were the closest to Mr. Duncan. The real issue was that, and she'll tell her story, I'm sure, in her book, but when you went into that apartment, it was clean. It was bleached. She did everything to protect her family. And so the real story is going to really have to come out, because what happened was she protected her 10-year-old son to make sure that he didn't get infected, and the two nephews. So at the end of the day, I'm sure I'll see a whole lot of stories. Everybody want to stand up. I'm a hero. She's a hero. At the end of the day, the real heroes are the people who lived in that apartment complex, who had to deal with CNN broadcasting that this thing is not working in Dallas County. And so I'm on the ground and I'm looking at CNN and I see the disconnect. And so the disconnect was in terms of looking for a national story to say something went wrong. No, nothing went wrong. It should be a model for other local health departments, other counties, other states in terms of how you respond to an Ebola crisis. So thank you all, and I'm sure we'll be around for questions.
Thank you, Director Thompson. Our next speaker comes by way of the Denton County Health Commission, and that's going to be Dr. Richardson. So please welcome Dr. Richardson.
I appreciate an opportunity to come and talk a little bit about what I hope is a slightly different message, and we're going to emphasize the consistency and the response of our partners, and we're very appreciative of what's happened, I think, during the event, after the event, with regard to communication and coordination. Those are cliche, I think, terms sometimes, and I'm going to hope to dispel a little of the vanilla language of coordination and communication and talk about real-world experiences for someone who had no cases. I need to acknowledge that. Denton County, we were very, very fortunate. We didn't have any cases of Ebola. And I want to applaud and commend Director Thompson and his staff anytime I had a long day, and there were a few, I would always think about his day and know that inherently it was a lot longer. And we were very impressed as colleagues and as, I hope, friends to see what happened in Dallas County and the professionalism and the competence that health department exhibited. So I want to, again, say we're very impressed as your neighbors to the north. So, you see, this is in no way, when we talk about our Denton County experience, this isn't a critique or a criticism of anybody else. This is what we did, kind of an individual, this is Matt's opinion, Dr. Richardson's opinion on what was happening in our neck of the woods when we started talking about this. And we'll talk about the universality of communicable infectious diseases and how that panic is contagious. And we'll talk about how to affect that. You see the truth, what I'm going to call a truth, is that you can't overestimate your agency's need to communicate, even if you weren't directly affected. So again, this idea of the necessity of information and people needing to hear what was happening in Dallas County, that was still important in Denton County. And you can't overestimate agencies' needs, individual professionals' needs to communicate. All of you probably already know that. I already knew that. That's an age-old philosophy. I'm not unique. I'm certainly not the first to tell you that in this audience or anywhere else. And again, you can't overemphasize this need. What's happening, you have to talk about what's happening to the people that need to know. And you see that list there, local providers. You need these situational reports. That needs to be common. By the way, it's always a surprise. Your friends, neighbors, your relatives, and people you don't know that have your cell phone number. Zach probably didn't know I had his cell phone number. He and I ate lunch right when I had gotten to Denton County, and I wanted to foster a relationship. I wanted to get to know him and his health department. Little did I know that was going to come in handy for me. I don't know how handy it was for him, but I had his cell phone number, and I had his text, and I used it. He'll tell you I did. It was probably a minor annoyance, but it was very helpful to hear somebody on the ground who is dealing with this issue and to be able to access them for information. I tried to make it brief, but it was very important in our response. There are layers to this communication, okay? I don't know how many of you have seen the movie Shrek, but Donkey at one point in Shrek talks about layers, and Shrek says something about it's an onion. He says, no, it's a parfait, and he wants to talk about more pleasant layers. Layers can be pleasant or unpleasant, but they're important. And what you see is the layers of communication and relationships you've got to preserve. You need to have relationships, local health department to local health department, local agency to local agency, local hospital to local hospital. And again, it's cliche, right? All of us know this. You can't overemphasize it. My relationship with the state, so I had been in Denton County prior to this. I've known Dr. Zredek for going on 15 years, I think. I've known Zach for several. I just met Vinny, but we're gonna form a better relationship. What's important is you know the people who you've got to respond to a crisis. We've all heard this before, but it's never more important than when there's a stressful, critical, crucial situation. Information needs to be passed. You need to know the people you're working with. Critical. Candy and Dr. Marshall from Collin County. I knew them. I've known Dr. Marshall for quite a while. I've known Candy by association for quite a while. Critical to know your neighbors in this type of event. Cell numbers, if you don't know the cell phone numbers of the people that you work with when the times get tough, you need to fix that today. You need to put them in your contact list. You need to highlight it. You need to star it. You might even consider putting it on your favorites. Director Thompson, luckily, sir, you're not on my favorites, but I'm thinking about it. I'm thinking about it. That's the type of relationship you need to preserve. If you don't think you have time for that, you're wrong. Whatever you think is more important that you're doing today, tomorrow, than a meeting of people that do the same kind of work you do, if you don't think you can carve out some time for that, you're making a professional mistake. Something you've got to maintain. It's a trust issue, incidentally. People need to know you and know that you can deliver what you say. They need to understand that you'll provide facts as possible. You will provide a situational update. You'll provide a briefing when possible. And when you make a commitment, you will keep it. That is your professional responsibility, whether you're a nurse in a hospital, whether you work for fire, police, EMS, whether you work in a local health department, whether you work at a federal agency. People need to count on you because you've been entrusted with that responsibility. And they need to know who you are. You can't just be a name on an email. They need to know you and know that you'll keep that commitment and know that when they need something, they can access you because that's your job. That was my job. I know it was Zach's job. And I'm very impressed at how he carried that out. And I'm very thankful that he took some time to acknowledge me when I texted him and said, what did you do about X? Now, he might text me back one word or he might text me back a paragraph. That was very helpful. I don't like meetings. I don't care for them. Sometimes I believe that I could be using that time to do something else. And almost in every instance, I'm wrong. Meetings are still important. When you think you've got to respond to something, you need to make sure that you have competent, efficient, effective staff members, and you need to be able to delegate, especially if you're in a position of leadership, so that you can attend and be accessible to people who need information. I think that, again, cannot be overemphasized. You need to talk about action items and timelines of your organization. You need to emphasize your response roles and the response roles of your teammates. You need to be able to provide that contact information to people who need it. Questions are important. When people have questions, you need to be able to have an answer, you need to be able to direct them to a resource, or you need to be able to go find that resource and close the loop. And what I found was, in Denton County, with 0 cases, there were lots of questions from school districts, from hospitals, from fire chiefs, from police chiefs, from the sheriff's office, from the jail, from daycares. They're all asking the same questions they're asking in Dallas. And we don't have any cases. But we took those same calls. We had those same concerns. We had people overreact to what really constituted the science. And we had to be the voice of reason, and we had to defend the position of the science and of the policymakers. And yes, whenever you have meetings, things are typically getting pretty serious. The exact message is important. Specificity and consistency, I think, are really critical. Here are some of the messages, and I use these as an example. I'm not going to read them bullet by bullet. I think you've heard these ad nauseum, but repetition is the mother of mastery. We had to continue to say the same things. I want to commend, again, Zach and Dr. Perkins. Mr. Thompson and Dr. Perkins did something that I'm very impressed with, and you've seen it twice today. You saw the picture, and what were they wearing? They were wearing this. Why? They were exhibiting the proper protocol for the science as we knew it. They didn't need to wear a spacesuit. They didn't need to wear Tyvek suits. They didn't need to wear SCBA systems. And the reason is the science didn't indicate it. They didn't rise to alarm and to panic. What they did was model what the public health messaging was. And that modeling is critical because the public then trusts what you say. If Matt Richardson goes to an apartment, and I did, for our first potential exposure, I had some staff with concerns. We had some training concerns like everyone. I will admit that we had some PPE concerns, and yet we followed the science. And I had some staff members that balked a bit about that. And so I went to the apartment with our nursing director, dressed like this, dressed like Zach. We interviewed the patient, we began the contact tracing, and we followed the public's health. I didn't get Ebola. That contact didn't get Ebola. The members of the apartment didn't get Ebola. Why? Because the science held. And we wanted to mirror a consistent message. That was important because I think that builds trust. That people didn't sense hypocrisy in what we were saying in Denton County. What we were telling our hospitals, what we were telling our police force, what we were telling our first responders. That was important, I believe. Panic in politics. Panic is contagious. Political elements can affect the messaging. The media cycle can incite or quell panic. By the way, as a public health official, my job is to utilize the tools with the media to get my message disseminated. The media's response to that is it's not within my control. That's not within my sphere of influence, right? Really what we see is that we can only put out the message that's consistent and that follows the science. And how that's received is a challenge. But I've got to take the first step. My staff has to take the first step in describing in a clear, concise, cogent fashion what's happening. That's our responsibility. My experience is that when you are very, very deliberate at doing that, it goes better. It doesn't go perfectly, it goes better. Recognizing your role is important. Recognizing that sometimes you have to recommend or implement a response that's counter to public opinion. I think my colleagues would take a nod to that. It's hard to win a popularity contest when it's a crisis, so you don't want to try. You want to represent that professionalism and your knowledge, skills, and abilities in your chosen discipline. And I'm so impressed with my colleagues in the Metroplex and how their departments exhibit that. But we have to tell each other that. And we have to support each other when that happens. And we have to commend them for staying the course, sometimes within public opposition. Sometimes with your supervisors. I'm an appointee, as is Mr. Thompson, of political elements. And I'm privileged to do so, and I work at the pleasure of the county judge and the commissioner's court. And I value that relationship. But they are also paying me and appointed me to give them the best knowledge on public health that I can. And I take that very seriously. And I understand my role as an advisor and a subject matter expert to them. I understand their role as to making public policy within their legislative authority. That's a difficult balance. Here's some of the messaging. You've seen some of these. This shows the gamut of simplicity to technical aspects, again, with CDC, NIOSH, OSHA, some of the recommendations that came forth. We did what other departments did. We put that on our website. We talked about social media, and we tried to disseminate this in public health alerts and public health advisories. We did what we could to get this information across. But you saw the simplicity to the complex. Again, I'm not going to read these bullet points, some of which because I have trouble with multisyllabic words, so there you go. I've got a solid third grade education, but you see some of the specificity and some of the clinical language that was needed for the providers in our county. With your local public health department, that's the level of discourse you need to be having with providers versus the public, but you've got to do it all. And in agencies, whether it's hospitals, you need to be able to communicate to your provider mix. You need to be able to communicate to the random, potentially homeless individual that comes to your ER at 3 a.m. You've got to communicate that entire spectrum. And your health department needs to assist you with that in partnership with the state and federal agencies. Again, coordination. I almost hated to put it on a slide because it's so bureaucratic and it's so generic and it's so milquetoast. I can't help it. We've got to talk about it. We've got to talk about this idea of teamwork. We have to talk about trust. We have to talk about meetings. We have to talk about emails. We have to talk about texts. We have to talk about being intentional that you meet with the people who are responding, that you are available by cell phone, that you have a conference call at 8 p.m. or 10 p.m. I was privileged again to be able to talk to Dr. Zaretic. I spoke with Dr. Lakey, the Commissioner of Health for the state of Texas, at 11:30 one night on the testing status of a sheriff's deputy. Dr. Lakey and I had a disagreement, and we were able to move forward because we knew each other personally. I was able to submit to the authority of the Texas Health Commissioner on that particular issue. I believe the science was borne out, and that partnership was important. He knew me by my first name. I knew him. I had his cell phone number, and we had already known each other and worked together so that we could talk at 11:30 at night. Critical. There's no way to overemphasize the importance of that relationship. And when I say relationship, again, it's kind of a general term. a friendship, a professional trust. He's going to do what he says, I'm going to do what I say. There's no replacement. It's invaluable. You can't put a number on that. And I know you've all heard this, right? This is not new. I am telling you, whatever time, whatever money, whatever effort you're putting towards this, resources, it's not enough. If you think you've got great relationships, you need more. If you think that you know how someone will respond in a crisis, another agency that you're going to interact with, you need them to send you their plan. You need to familiarize yourself with their frontline staff, or your frontline staff needs to know their frontline staff. And if that sounds like a waste of time, I'm sorry, it's not. Levels of access and response. I think it was helpful that I was able to talk to Zach. I think it was helpful that Juan Rodriguez, my chief epidemiologist, was able to talk to Wendy Chung, Dr. Chung, his chief epidemiologist, that we were able to speak with Dr. Marshall in Collin County, that I didn't know Vinny, but I knew Vinny's staff. I knew Dr. Curian. I went to school with her. We had maintained those relationships. Those friendships, I would see them at meetings. Vito Magala, I've known for probably pushing 15 years. It's good to see him this morning. I've been out of touch with him for several years. I'm going to remember that he's now at North Texas at the Health Science Center, that he's back, and we're going to go to meetings together, and I'm going to get his cell phone number, and he probably doesn't want to give it to me, and I don't blame him. We're going to do that because I might need some subject matter expertise in biostatistical analysis on case trends of disease X. I don't know what the next thing will be. Dr. Magala might help me with the next thing. Truth number 3, I think I probably skipped 2, but I know that you can read. Truth number 3 is decision makers need you to tell them what they need to know, and they need the opportunity to ask you questions. And you can't not do that. You've got to be accessible and be available, even when it means you could be doing something else. Nothing more important than working with people that make decisions and reminding them of the science, reminding them of what's at stake, reminding them of best practices. It's hard to know what to say about consistency. Again, I think you know this. This is really a presentation of telling you what you've heard before. It probably works in theology. It probably works in practice. It works in anything. It's like a preacher said, you tell them what you're going to say, you say it, and then you tell them what you said. Be consistent. The agency messaging needs to be consistent at every level. Remember, we talked about accessing levels, and we talked about the Shrek layers. My frontline staff and reception needs to be saying the same things that the health department director is saying to the mayors, right? It can't be different. You lose trust, you lose credibility, and you lose the public. And we're the public health department, the public is pretty important. And so we have to be overly cautious in our messaging crafting. And it must be consistent. It can't be wishy-washy. It can't be hit or miss. By the way, one of the consistent messages I said at the beginning, and I know my partner said it, is that this represents 4 decades of science with Ebola. But we recognize that as we go through this crisis, the science could change. If it changes, I will tell you immediately. And we will update our recommendations based on the science. I never said that this is how Ebola works, and that's the end of it. What we said is this is how we know Ebola works, and if the science changes as we go through this experience, we will adapt. By the way, the science did not change. And we also highlighted that. Today, the science is the same as it was in August, as in January, as in 1978 and 1976 when we found out about Ebola Zaire. But public health officials have to be able to say, it could change, and if it does, we will let you know immediately. But we didn't have to, because it didn't change. Establish those facts, explain that if they change, you'll communicate it, and don't deviate from the principle. If you make the commitment, you'll tell somebody an update, You better update it. We learned that lesson, and we've learned it the hard way in the past. We really probably didn't communicate. Now that I've talked about what I think is important, we probably didn't do it enough. There were still people, organizations that felt like they didn't have enough information when they needed it and when they wanted it. So we can do a better job. We're going to do a better job. One of the things my staff and I keep talking about is, you know what? Maybe, you know what, Zach, maybe we did think of ourselves as a little bit of a hero, and we're probably wrong. We needed to communicate more often with people that needed information. And some have been appreciative of what we provided. We probably didn't do enough. And whatever you think your organization provides in way of communication, I'm going to be the outsider to tell you it probably ain't enough. You need to do more of it. You need to be more deliberate. You need to be intentional. You need to be specific. And you need to be basically repetitious. Some of the messaging, you've already heard it, press releases, website, updates, social media, interviews, community meetings. We talked about making scheduled times for our staff's benefit, internally and externally, about a daily briefing. We might send 5 or 6 bullet points in an email to our internal staff. What I found was the reception staff at the front desk wanted to know how it was progressing so they could communicate to the public. We didn't always do a great job at updating them on the status. And so internally, we've made a commitment we're going to do more of that. What we'll do next time, you see those bullets. We're going to utilize social media more effectively. We're going to talk about that, on how we can do that and how often to update that. We're behind some of our partners, I think, but we're going to spend some resources to rectify that gap in the service. And again, cultivating not just relationships, but friendships. I want people who know me, and I'm like super glue. A little bit goes a long way. So I've got to be careful. I think sometimes I'm also like radiation. You need some time and distance. You need a short amount of time with me and probably some distance. But that same thing means that I've got to cultivate friendships with my colleagues, and that takes, you've heard it, that takes an allotment of the variable of time in my day. I've got to go to meetings. I've got to send them updates about what's happening at my health department, because it might affect their response moving forward. Okay. And that is it. I appreciate your time. Thank you very much. I've got business cards for those of you who are interested. We appreciate your involvement today. Thank you.
Thank you, Dr. Richardson. Next up on our agenda is the Tarrant County Public Health Director is Vinny Kanasia. Please welcome Vinny.
Well, good afternoon. I'm Vinny Kanasia, Director of Tarrant County Public Health, and welcome to Tarrant County, everybody. And thank you for UTA and OSHA to put this event together here. I'm very glad that we're able to host this in Tarrant County. And I'm thankful for our colleagues to have shown up here and to talk about this important topic. And I have a couple folks here from Tarrant County that have come here to show their support. One person's Tanya Hunter. She's the manager of our Tarrant County Emergency Management area. And I have a couple other staff from Emergency Preparedness, Carol Linda Gibbons and Leslie Rodriguez. And then last but not the least, I have Dr. Anita Kurian, my Associate Director at Public Health. She's been a long-time Tarrant County Public Health employee and very well known and respected in the area, as Matt was already alluding to earlier. Now, my disclaimer here is that I'm not as entertaining as Zach or Matt. I'm a pretty plain vanilla guy. So I'll try to pepper in some humor, but they're very hard to follow. So we knew on September 30th that Ebola had hit the United States, and for me that was a very important time because I was brand new to public health in Tarrant County. It started on September 15th, so that was really the first couple of weeks on the job. And that was a very interesting time to have landed in the middle of a very hot scenario. From that point on, we sprung into action at Tarrant County Public Health and had great support from Tarrant County Emergency Management, the county administration, and even the elected officials. And I came from Detroit metro area, and that was quite a reversal of what I had seen in the past and experienced in the past. So it was a very welcome change that people were so integrally involved in what was going on and were interested in learning about public health and how it impacts our community. So the major challenge that we found immediately was the availability of credible information, because there was a lot of media coverage, all kinds of stories were being covered, and it was hard for John Q. Public to figure out what's true, what's not, what's credible, what should we follow. So we, as Tarrant County, decided that we're going to be the source of credible information for our community members, and we went into a information gathering and dissemination mode at that point. Luckily, we did not have an Ebola case in our community at that point, so we had some extra time to be able to develop that information and get that out. And then one of the challenges that started to appear, because everybody wanted answers, do we have somebody here in our community that's affected? And how are we going to deal with that? And that information was a little bit slow to trickle out. We in public health understood that that information takes time to gather. It's going to take a little bit of time to go through all the contacts, who belong to which county in the neighboring area, because we're in a large metro area. But there was a lack of patience on part of our partners as well. So we were trying to address that as best as we can. And there were a lot of quick-moving decisions that were made in those 2 or 3, 4 days before the information emerged. So what we started to do was, gather the science behind it and explain those decisions, even though they weren't ours. They were made by other partner agencies, whether it was the state health department or other partner health departments, and we were trying to explain the science behind those decisions. So we were all on the same boat. So like Matt said, consistency was the key. We didn't want to appear that, oh, by the way, this agency is doing this and we're doing that. It doesn't help with credibility of public health information. Our, again, biggest challenge at that point was fear and misinformation among the community. And the biggest weapon that we used against it was education. Let me see if I can get to the next slide. And in disseminating the public health information, we found some great partners. City of Fort Worth Emergency Management came to the forefront. Tarrant County Emergency Management were great partners in bringing us together at the Joint Operations Center, and we held conference calls with our hospital partners, with our fire, EMS, and first responder local emergency management partners. And of course, we started talking to our charity organizations. Some of them actually go receive refugees coming from African countries, and the information was so wide and loose that they were worried about anybody coming from Africa. So we were there to help them understand, what are we looking at, what do you need to ask if somebody comes in the middle of the night, lands off a plane, and how do you prepare yourself? We gave update to elected officials, mayor's council, of course, our commissioner's court. And then during the scenario as it progressed, we also ended up having conference calls and then an in-person meeting with our school partners, because there was a lot of information that was needed, especially after the flight situation happened. There was a lot of misinformation about who's a contact, and people were worried about contacts of contacts, and oh my God, do we need to shut down the schools? No, we don't. But we explained the science and also left the decision up to them, because they are independent school districts, and they can decide what they see best in their community and how they want to deal with the parents and the situation in their schools. But we explained the science that, given the information, our understanding is that there is no need to shut down, there is no need for any special precautions, but if you want to do what you need to do, go ahead, you're independent. So here's an example of a joint effort with City of Fort Worth. Very early on, we helped develop a algorithm for the City of Fort Worth and MedStar, the ambulance company in the area, to start using. And pretty quickly that spread to other entities who started using this algorithm. Now this was a very painstaking, long process, I'll tell you that, and a lot of meetings, like Matt was saying, that were spent trying to develop this. And also, then the situation emerged where we found out that there was a person who was a close contact of one of the nurses who was diagnosed with Ebola. and was a Tarrant County resident and was expected to come back to Tarrant County for the remainder of the monitoring period. So the situation emerged where we needed to find a place for this person to be housed and taken care of for the remainder of the monitoring period, and there was discussion that possibly we will need to write a control order. Then our Tarrant County Community Development and Housing Division sprung into action and literally overnight was able to find a house, got it furnished with fridge, TV, internet, utensils, you name it, toiletries, everything, ready to go. Luckily, the situation didn't develop. DSHS stepped in. Dr. Lakey wrote a control order, and Infectious Health Presbyterian was very generous of keeping that person there for the remainder of the monitoring period. So we did not have to deal with that in our community because that could have led to a potential issue because the local jurisdiction where the house was not very happy that this was going to happen. So we averted that situation. But in preparation, we did talk to our law enforcement officials that if there is a need for any kind of a law enforcement action around that area, and they were worried about what training they need, how they need to understand Ebola. So that did happen in our community. Now, there was a very coordinated response with first responders, and there was a lot of pressure from the community, from elected officials, from first responder community as well, that they needed some sharing of information. Now, there's different opinions in different parts of the state. We, reached out to our DA's office, and they came to our rescue, issued a legal opinion, and I leave opinions up to the attorneys, because they're the best to defend them. And then they helped us craft a HIPAA letter, which allowed us to share very, very limited information. The way we did it was we didn't share the name of the person or what disease they're being monitored for. However, very quietly, in a confidential HIPAA letter, we did share, okay, here's an address that we're monitoring. And it was to be only shared with the city manager and a key person who would put it into their CAD system as an alert. And the alert would simply say, you get a call from this address for some kind of an emergency run, whether it's fire, police, ambulance, whatever, alert would pop up saying call Tarrant County Public Health at 24/7/9, and then further discussion would happen. Now it worked almost flawlessly, and I say almost, because we also put in a letter that was a turn off letter, if you would. Now that the monitoring's ended, you turn this alert off in your system. So one of the alerts was supposed to be turned off on a Friday afternoon as one of the clients ended their monitoring period. And it did not get turned off, and lo and behold, on Sunday night, there was a call from that apartment complex, and an alert pops up. So we get a call in the middle of the night, what's going on? Is this something that we need to be worried about? And then immediately our EPI staff who were on call, they went in and said, no, this alert was supposed to be off, and so don't worry about it, go respond as your routine call. But it helped because, one, we knew that the system worked, and two, for us, it was a great way to maintain some surveillance because, on a day-to-day basis, public health was monitoring a couple times a day, depending on the level of, exposure that we considered. Some folks were being monitored twice a day, once in person and once on the phone, and some folks were being monitored just on the phone. And this gave us another avenue of surveillance. Hey, if in the middle of the night something happens and somebody calls an ambulance saying, oh, I'm now sick and I need to go to a hospital, immediately by default, that alert would also come to us because the ambulance is going to see, oh, by the way, I need to call public health for something. So that was a great way to add a surveillance tactic that is traditionally not used, and we got that done. Now, there is some state legislation around this because what we used was an interpretation of the law, and the legislature wants to clarify that. But also, as a public health entity, we're also worried on how sometimes things can overreach. The way I read the current legislation, it actually forces public health to share information, including names, what diseases we're considering, and all of the details, which a lot of times can be very tricky. So we'll see how that legislation, progresses and goes from there. One of a few of the lessons that we learned was that fear is our biggest enemy. It's again one of those things that's an obvious statement, but we need to say that and remind our community that fear is the biggest enemy, and what they can do is educate themselves. Work with your local public health department, work with the state health department or CDC, and learn about these, disease occurrences that happen, and make your best call at that point. Do not, feed into the frenzy, because that's what we saw a lot of times happening. People were, like I said, worried about contacts of contacts, somebody threw up at a local facility, and oh my God, they must have Ebola. Well, no, they just probably ate a bad burger. So things like that happen. But education really was the key to fight fear. And the thing that has been repeated over and over is educate early. Get the facts out fast. That way, the misinformation is cut away right away, and the facts take hold. And provide only credible science-based information. No matter what decisions are made, try to make sure you stand by the science, because not all decisions are made by the scientists. So there are other people who make the decisions responding to what the public is wanting to do, but you must stand by the science, because that's the only way we as public health can survive, by following the science. And then, of course, talk to your community. I mean, that's just so much. Sometimes you're in the mixed up response, trying to address the situation, but and community includes not only just the general public, but your hospital partners and other partners, and including staff within public health. That was something that we tried doing on a very regular basis in our health department, and it was very appreciated by a lot of staff, because what's going to happen. Next thing, the media is on site and they talk to the front desk. Well, what do you know about Ebola? And if they have, again, credible, clear-cut information in a concise email, they can quickly pull it up. Well, here it is, and here's a public information officer that you can go talk to. And we did that, and we learned that this was very valuable. In summary, there are still a lot of unanswered questions. Of course, in our area, I think they picked earlier, Richardson was a facility, a hospital in that area that was determined to be a Ebola treatment center. Now it is not there, and we don't have anything in the local area that is designated that way. The nearest facility is in Galveston, so that's a concern. There are still concerns on where people would want to go for evaluation. We tried to coordinate meetings with our local hospitals. Of course, nobody jumped up and wanted to say, hey, we're the first one to bring everybody here. So sort of there's an unwritten rule, hey, wherever they want to go, everybody be ready. And I feel very confident that at least in our community in Tarrant County, the hospitals are fairly ready. They've done a great job in preparing. Of course, they have questions about PPE and the availability and the training and practice behind it, but those are everywhere. Barring a couple of institutions at Emory, nobody feels as prepared as those institutions are, but they're doing a great job in learning as we go along and preparing for any eventuality. So Tarrant County is working with all our local partners and our regional and state partners to address some of these gaps the best we can, and trying to get to a level where we all feel comfortable that if anything happens, we're going to be able to handle that within our community and not even need a treatment center possibly to take the person out. Overall, and again, remember, I'm now here for 6 months as a public health director. When I came, it was only 2 weeks. And as an outsider, I found that the response here in Tarrant County was very well coordinated. Coming from the Detroit metro area, this was very, very refreshing change. People talk about government and bureaucracy. I really thought this was a very fast-moving response to a very fast-moving situation. I've never seen government gel that well. Different entities in government work together and make some very key decisions to address the situation. So this was a very good response in our mind, and we see that across the metro area. I think the public health agencies handled that really, really well and did a tremendous job. So if you have any questions, I'll be here, and I have business cards for you all as well. Thank you.
Well, since we've started, our discussion panel has actually grown as all of our presenters have agreed to come up and be a part of the discussion panel. But we're also lucky to have a few others here. Dr. Magala from the University of North Texas Health Science Center. We welcome him to come up. And Greg Guthrie. There he is. All right, he's going to be joining our panel too. Greg is with he's Emergency Management Specialist with the Dallas Office of Emergency Management. So if all those going to participate in the panel could graciously make your way up to these chairs, we're probably going to have to add a few chairs. We also have Ricky Reeves. He's a division chief from the Louisville Fire Department and EMS system. Thank you for coming, Ricky. Just as a little bit of framework for how we'd like to see this work, as you ask your questions to the panel, if you could just stand up and project that as clear as you can, and try to address it to the panel member that you would like to have that answered. And as the panel members, if you could, for the benefit of those viewing on the web stream, just briefly repeat the question and then go into answering it, and we will get to that as soon as everybody gets their seats. Thank you.
Mr. Boyd, this is for OSHA. What role, if any, would OSHA play in an infectious disease outbreak?
Now, it all depends on the situation. With regard to the Ebola outbreak, we were acting in compliance assistance. So we were interested in finding out how the nurses contracted the disease, but we were not there on enforcement capacity. So it all depends on the situations. Should there be another situation in the future, we could be there in enforcement, which would involve an actual inspection and possible citations for any type of violations found.
Is that right here?
Good morning. In reference to pre-hospital settings, is there going to be more information set out for hospital settings with reference to ambulance services and how we take care of them as far as OSHA? I believe that some of this is the actual municipalities, not necessarily government. Is that correct?
That's correct.
And what are the guidelines that actually we need to make sure that we're following as far as the hospital setting plan of care? A lot of people are first responding to firefighters.
Yeah, sure. I can give you some perspective there. I'm not sure if you're familiar with it already or not, but CDC did put out a guide for pre-hospitals, so it covers ambulance personnel, it covers personnel working in public safety answering points, tries to give them some guidance on what they need to do. This is kind of a tricky one because of the way OSHA's jurisdiction is set up. In federal OSHA states like Texas, OSHA doesn't have authority over those types of public sector personnel. They're only covered in states where there's an OSHA state plan set up. So in an OSHA state plan, public sector employers, assuming that the state plan does cover the public sector employers, would have to cover those workers and comply with OSHA standards. It's really a guidance issue and up to state authorities to cover that in a state like Texas where it's a federal interstate.
And I want to introduce Ricky Reeves, Chief Reeves, with a pre-hospital discussion too as a division chief for EMS. And I want him to talk about implementing the local recommendations along with some of the CDC guidelines and talk about coordination locally. Since you asked the question.
So even though we're not regulated by OSHA, we look at all resources that are available. So we took the CDC guidelines. They actually have a checklist that you can follow, and it's pretty extensive. Most of those things we already have in place. It allowed us the opportunity to go back and go through those and update them. And we use that checklist to be able to come up with what we needed to try to protect our folks. The number one thing is we practice universal precautions, and I think number one thing that we didn't expect is the Ebola virus. We practice on hepatitis and HIV and that kind of stuff, and so we get complacent to some degree when we have something outside those norms. Dealing with the EVD is a little different. It's still same thing. You do your questions. You're not gonna bear hug anybody. You're gonna be at a distance. You're still gonna be able to wear your PPE to come in and treat the patients. Everything slows way down, and that's the thing that we had to get over to people. Everything stops or slows down. Step back, take a breath, and start that process. But number one, universal precautions, using the guidelines that were prepared by CDC, and using some of the PPE, and we were able to be successful. The thing you have to remember is the three individuals that first seen Mr. Duncan were EMS people. And those guys went in and were warned at the door that there may be something here. They stepped back, gathered their PPE, went in and dealt with Mr. Duncan when he was pretty much a high state of with the disease, and they were fine. They followed the science, and that's the thing you have to do is follow the science.
And that's what we tried to make sure that all of our participants in the EMS realm did, was follow the science, protect your people, slow down, take a breath, and not rush into anything. And we're able to come through it. Now, it did allow a lot of the EMS agencies throughout the Metroplex to get together and decide how we were going to prepare each community, what kind of response. Most of our EMS are not large municipalities. Some of them are small volunteer organizations. They don't have all the resources. So as a group, we would come together and like in Denton County, we'd come together with our Denton County fire chiefs and all the providers. We had meetings with Denton Health. We got the science from the horse's mouth, basically, of what to do and where we need to build up our PPE, where we need to do our training. We got training, devised a process that we would use for protecting our individuals, who would transport the patient. We had one. Because the thing about it is we knew about Mr. Duncan. We knew about the two individual nurses. But if Mr. Duncan got here with nobody knowing about it, somebody else could also be there. And so that was our biggest surprise, is to make sure that we didn't get a 911 call and be another ED patient.
Yes, sir. Hey, along the same lines, Mr. Reeves, what are the biggest concerns of first responders with infectious diseases?
Well, I think that the main thing is having the appropriate PPE. CDC made changes constantly with some of the PPE variants based on hospital treatment. Again, universal precaution is the number one thing. If you follow it, I think you're pretty good at protecting yourself. So more education in that realm, the availability of PPE for the first responders. Like Dr. Thompson said, funding for that type of PPE training it's just not filtering down into the first responder realm as much. After 9/11, we had a lot dealing with chemical and that kind of stuff, but biohazard is not so much prevalent in the training. So those are some of the bigger options.
And following along there, it's a little bit off the direction. When you see organizations like SETSBEMS or folks like that, maybe together with our national EMS associations, do you see them having a bigger role in this?
I think so. I think the larger the audience is, the more that we can get legislatures and congressmen to be able to support funding streams and be able to get it filtered down into the training segments that we need getting PPE. One thing we found out with PPE is Dallas-Fort Worth area was impacted. But the minute you made a phone call, the rest of the nation heard it. And so you couldn't get anything. So things that we asked some of our suppliers to institute was, we need it now, because we're in the battle, to spend some of the other orders, and that may need to step up into the federal government level to be able to direct some of those avenues and assist in. And some of those organizations can assist in that as well.
And not to be before that, where do you see the issue of registry? They seem to be relatively quiet.
Basically, National Registry of EMTs is mainly the training background and certifying regulations. So there wasn't much there to do. I think you're going to see some additional training come out in required infectious disease, maybe expand that role a little bit. But in this type deal, it was more the response, and it wasn't really more for the education side at that point from the way the National Registry of EMTs works.
And I'm talking on behalf of College County. I'd like to address this back. It's mad and community. I know that we could disrupt Dr. Aslan on the county clerk marshal. You got to talk a little bit about your epidemiologist role, so I don't understand the role. Specifics about the other thing I'd like to ask each and every one of you have all of your responses. After this, we found out that one of the things that many people don't think about is the cargo space is pre-bought up way in advance. So anything that's coming from outside of this country is bought up by the Walmarts and the Targets and so forth. We all need supplies. We don't have that space. It's not available to us. We may have to have some legislative backing. Say, hey, we have got to put these holes, we keep those critical supplies on these ships and get them over here. So that we have, I would like to see if either of you have all the supplies that you ordered. I can tell
Sure. Well, no, we don't have all our supplies, so that's something we have to work on. But Kenya, again, thank you for reaching out during the Dallas Ebola situation. I always appreciate you contacting us and that relationship we have as local health directors. I want to be very clear. The overall response, while we have our EPIs, but there are various programs that fall under public health. And contact tracing is not new. Everybody's making that appear to be, that's what public health departments do, day in and day out. It increased under this scenario because the number of possible contacts. At one time, we thought we had 100 contacts, then it got narrowed down to 30, so the numbers got smaller and smaller. So you expend a lot of time doing the contact tracing that is a part of your overall public health follow-up. And that's what we do, whether it's TB, HIV surveillance, that's what we do. I hope that's not all we're just doing for one aspect. We should be doing it for every area. And so when you talk about contact tracing, that should take place throughout the process. The difficulty is that you have a defined name and location. In the other aspect of public health, it is difficult to do contact tracing or public health follow-up on the homeless population. So I want to be very clear. We see a lot of credence to, while I give credence to EPI, that's what they do, but clearly you had two populations. The population everybody focused on was Louise in that house. The concern I had is that you had hospital workers who should have been a part of that equation. And so it became a part of the equation after we had the first confirmed case from a hospital worker. I think the teachable moment is when we began that process, we need to look at everyone as part of that contact tracing and ensure everyone is following up on, and I'm not going to say control orders, but there should be some kind of order where they can't leave. Let me give you an example. The control order that happened with Louise told, as I hear it, is that one morning the kid in the house got up and wanted to go to school. Well, what 10-year-old wouldn't want to go to school? He got up like he's supposed to. They said, don't go to school. Well, that's where my friends are. And so all of a sudden, and I'm standing at the same press conference, and I'll be frank, and I don't have a problem. Everybody made a big deal out of it. This was a 10-year-old who got up that morning and wanted to be with his peers. Was a court order, control order really needed?
Well, and I'll address a couple of things, especially related to epidemiology. I think our team did a fantastic job. One of the things that people don't realize is that, yes, the situation happened around the original Ebola case, and, there was a lot of attention, and now the attention seems to have kind of gone on to other things. However, we've had a very sustained response in epidemiology, from the original Ebola contacts to now travelers that are coming to the area. Our epidemiology staff have been working nonstop ever since September 30th. We've had holidays in the middle, we've had snowstorms, ice storms, nonstop. I mean, and some of these things have been, they're sliding on ice, going to somebody's house to monitor them. So they have worked tirelessly, they've had their 24/7 number on, and that's what you get taxpayers' value right there. So they're working tirelessly here, and they've protected our community to the best that they can. So I cannot thank them enough for the response that they've provided. And we've had a ton of contacts and travelers in the area, so the numbers are quite staggering if you look at those. And in terms of supplies, everybody's in a different spot. I know that we don't have our supplies, but there are some hospitals in our area that got lucky. They've had their supplies, arriving. I know that I think our sheriff's department had ordered some supplies even before this happened, and they got some of their supplies in their hand. And there were some other law enforcement agencies that we talked in the area that they got some hands on some supplies. But even though we have some, the challenge that we're running into is everybody ordered from, I guess, different vendors, so it requires different trainings and different things. And what we're trying to do now is there's some Ebola funding coming for public health and for hospitals. We're trying to work with our regional advisory committees or RACs and to make sure that we work in a coordinated fashion, hopefully get similar supplies so that there can be a common training program. That way, just in case people need to help each other out, that they can, really train each other and, use the other folks' supplies. If I was able to say, okay, I'll take some from public health and you need it today, well, then they know how to use this equipment properly. So some of that, work is still going on in a very coordinated manner. Again, everybody is in their own place, so there's not going to be a perfect solution, but we're trying to reach to a common consensus if we can.
I would just add, first of all, I've got to basically say ditto. There's that. And then I would say that with supplies, that's a short-term issue, and we've got to solve it. I think at Denton County Health Department, we still are lacking some PPE. The bigger issue is the conversation I think you're getting to, and I think we're getting to nationally. Chief Reeves mentioned immediate supply, the just-in-time supplies, the short-term supplies, versus an extended training program that requires you to be prepared for any event. I think we could make do in an interim, but as a health department, we're probably not where we need to be for a sustained event. I think hospitals fall into that category very definitely. I think I haven't spoken to officials from Dallas Presby personally, but I suspect they would advertise the difficulty in a sustained response. We've heard numbers of PPE changes, and we've talked about the staffing requirements. All of those are factors. You know those, Candy. You probably should be up here instead of me, honestly. I think Collin County had more contacts than Denton County to trace. We have, I think, just a few fewer than 40, but we are also in a sustained response. I think I do want to end with your question. I want to bookend these answers with public health. A little known aspect of public health, and Zach mentioned it at the beginning, is this idea of capacity, and that we have to sustain the ability to respond and scale from common TB investigations, common STD investigations, common communicable infectious disease outbreaks that happen that are sub-media. The things that the general public, that you as other organizations don't track, don't hear about, don't know about. That's happening for us on a very routine basis. What is critical? This was exhibited by Dallas County. It happens in Tarrant, Denton, Collin. We have to maintain as health departments an ability to scale up. We've got to cross-train individuals to become the disease detectives, to assist epidemiology whenever we're doing contact tracing. And we're a unique organization. The discipline of public health is unique because the general public expects us to respond in anthrax, West Nile, SARS, EB68, Ebola, name the disease du jour, and you're going to expect your public health department to respond, to be competent, to be vocal, to be a resource for community events, to be a resource for the general public on the end of a phone, on a hotline. You expect your health department to meet all of those needs. And you expect public health officials to coordinate with fire, police, EMS, to work with the governor's office, to work with the commissioner of health, to work with Health and Human Services at the federal level. That is your expectation. And you know what? That takes money and it takes people. And that's one of the challenges that I think Collin County experiences, Dallas County's experience. One of the things that Zach and I talked about in a very public fashion was when they talked about Ebola money, and then they talked about reducing public health preparedness dollars. Are you kidding me? We just had the first case of one of the most highly infectious and contagious diseases known to humankind, and you're going to cut preparedness money? This is a critical discussion. So when you hear about budgets, and you hear about rhetoric at the state level, and when you hear about taxes, remember, those dollars get to Texas, and those dollars get to your neighborhoods. PPE for Chief Reeves, epidemiology for Denton County, boots on the ground for the M Streets in Dallas. Remember, Ebola response doesn't just happen. It gets paid for. And we're asking for those dollars from the legislature. We're asking for it locally because we need it, because you expect it, and you deserve it.
I just have a few questions. Chris Brown, you can answer three. You had mentioned that there's 35 treatment centers. How many assessment centers are there to date?
That I can't answer for you, and we've been trying to get a handle on that as well. The number has been so in flux with CDC over the last number of months that we're really not sure. Our understanding is that most states have at least one assessment center, but beyond that, I don't really have an exact number.
Thanks. And then, as far as flushing, as far as flushing wasted bodily fluids, what is the current standard for Ebola positive patients?
So we had these discussions with CDC, and no one has really made a concrete recommendation or tried to put out a standard that hospitals or other entities should follow to this point. But the consensus really is that the wastewater treatment systems are designed already to be able to handle that. So they should be able to have something flushed through the standard municipal sewage system, go to a wastewater treatment plant, and there not be an issue. Our only area of concern is for workers in two instances. One, if there's not care taken when flushing things down a toilet, for instance, the aerosol that's generated back from the flush may present a hazard. In some instances, though, it's likely to be so diluted it's not really expected to be an issue. And then the other issue is when maintenance workers come in and they're having to unclog a stopped up toilet or a stopped up drain, and the piping obviously is not clean. It's, could potentially be contaminated. So they need to be wearing the same types of personal protective equipment that the healthcare worker who would have contact with similar surfaces might wear when they're doing that sort of job. But otherwise, in short, flush it seems to be okay.
Thanks. Last one is somebody, whether they're low risk, medium risk, or high risk, they are now driving their vehicle to the hospital, or their family member potentially is also exposed, you don't know at that point. What would one do with the car?
That's a good question. There were some discussions, and this is another thing that we never really came to a conclusion on because we never really had to. It didn't become an issue. We didn't have to deal with it. CDC was looking, through NIOSH, was looking at ways to sterilize vehicles that were used to transport potential Ebola patients and persons under investigation for Ebola, especially in instances where it was later confirmed that the person did have Ebola. And their focus really was on ambulances and other sorts of municipal vehicles that were used to transport patients. And I know that they looked at a variety of options, ranging from chlorine gas to other disinfectants that were on EPA's list, all of them disinfectants suitable for Ebola, but they never really came to a conclusion. One thing that I think is important to consider is that in a personal car, or something along those lines, there's lots of soft surfaces. And when we were dealing with similar soft surfaces in patients' apartments or in a hospital setting where you have all sorts of draperies and rugs and textiles and furniture, carpeting, things like that, almost the unanimous conclusion was that those sorts of things really just have to be discarded. So if that means scrapping the car, then that may end up being what happens.
Thank you.
The other question is, piggyback on what Dr. Richard said earlier, Ricky, you may be able to expound on this a little bit more. I'm not Dr. Zurek, we have more information. We've talked about Zach did the funding that's coming out, or supposedly will be coming out in the future for those assessment centers and treatment centers. My concern is over those areas. Of course, that's where I operate at. So I lean kind of inclined to think, are those guys ready? Do we have enough of those going around? Can one of you guys speak to the benefit of the audience, some of the funding that's coming down there in different categories, so that it doesn't impact APP, so that it doesn't impact PhD. There are specific other buckets that's created for this.
Well, I'll address that from a public health preparedness funding standpoint. So the Ebola funding that's coming is coming for a very limited purpose, and it's considered to be a one-time push. I don't know if they have any other plans to give any further continued support. But the public health emergency preparedness funding, has been around for more than 10 years and has gone through several cuts. And it's reaching to the point, for example, Matt mentioned earlier, we're especially in the larger metro areas are facing huge cuts. And in our epidemiology capacity, almost half of my staff are, funded through preparedness funding. So that's a major concern. And I don't know that the one, push for Ebola funding that is for a very specific purpose is actually going to resolve that issue. Because, it might, end up getting, used up in buying supplies or, one-time things that we can do. We can't, sustain staff and a sustained response on that funding. So that's the public health side of things. I'm not sure, how they're going to plan to use the hospital Ebola funding. And that's a bigger bucket, if you would. And that might be for a longer term because it's obviously larger amounts of money.
I will say one thing. We got to be very clear. The point was made. 9/11 is when public health funding increased, and we began to see the public health preparedness. We just had the first Ebola case in the United States. We had 2 nurses who were infected. I think it would be a disservice from the federal government standpoint not to ensure that hospital readiness funding and local public health departments who are on the front line, as we talk about the litany of current diseases we're tracking and emerging diseases. And I don't think the public understands what we all do day to day. But they understand it when you get the first Ebola case and they call you every minute and say, what are you doing?
On yourself.
On yourself. So I think the key point is that we really got to show the great work we're doing across the board, from our first responders to our nurses to our physicians to everyone who is involved in this public health response. And the best example, and that's why we said we focus on one division of entities, but let's be real clear. This was a Dallas County Health and Human Services Department response. And so when you look at it, there was the funding that was put, or the funds expended, we will never get back in personnel. There are a lot of people who still, including Dr. Perkins and myself, who have not had a vacation camera, Erica. So when you look at it, you expend a lot of hours and time because that's what you do. But it's disheartening when you see that the funding cuts or the potential funding cuts on an area that the public, not only from the standpoint, if you remember that apartment complex at Victory Medical, people were standing around and almost wanted to just drag that family out and get them out. That showed you the mass misinformation that the public. So we can talk about Ebola all we want. The biggest issue was managing the hysterical issues by the public regarding Ebola. And so we can manage, and then we did that. It was contained. But the perception in the public was what you couldn't manage. And that's where you're going to spend a whole lot of time. So definitely I agree that funding should be there.
Well, that's where I think the benefit of these focusing some of this funding treatment assessments, looking back at what happened, unfortunately, to Dallas Presby, they had a patient in there. We don't want to put another hospital to use their day-to-day ICU for that. So this treatment assessment center is critical of that. Doesn't, obviously, the management or mismanagement of the information or perhaps the perception of what's going wrong. And then on the heels of the lawsuit, not making an assessment of what's going on and all of that. Hospitals have to be leaning forward and looking at seriously these treatment assessment centers. That's going to be the battleground, not only for Ebola, but for these next high consequence diseases.
We were taught that the hospital is going to be the key factor in terms of our identification of potential outbreaks. We saw that with Ebola. That's why I put heavy emphasis on hospital readiness and whatever it takes in terms of assessment, because they're going to be the key. That's when public health, the amazing thing is we're coming in after the fact. I think everybody misunderstands it, is that this one has been confirmed as a case, so we begin our work. The key is going to be on the front end of who is actually assessing it, and it's called real-time information.
Well, and I think you've got to make sure that the funding not only exists for the hospital preparedness, but it's also got to get to first responders. We've taught our nation to call 911 when you need help. We're the first ones that walk in the door, and we've got to make sure they're trained, make sure they have the proper equipment, and they have to have the funding. For years, the United States has taken care of its health and made sure we eradicated a lot of diseases. We used to have a big insulator around the United States called the ocean. Now it's a plane ride anywhere in the world to be here in 24 hours. And we have lots of diseases that are out there in the world that we've never seen before that will eventually come to our nation. And I think that Congress has got to fund us money for preparedness in both public health, and it's got to fund us in the hospital preparedness. We've seen from Hurricane Sandy all the way down into the Ebola prices, lots of facilities are not ready. And we can't rely on local funding because it just doesn't exist. We can't tax the local people too much to be able to fund this. We have to rely on the government to do that. And I think the HPP funding has got to be increased. I think there's got to be additional funding added to that to take care of public health as well as our first responder organizations. And that has to be done. There's a slight increase because of this event, but it's a one-time push. It's not going to be sustained very long. And I think that's where we have to go back as a nation and push our Congress to say, we need to support the funding. We need to increase the funding. If we see the funding all over the world to protect other countries, we need to protect our own home front first.
We're talking about this when we...
Let's move on to the next question. And if we could, let's try to avoid turning this into a political question.
So we right.
Yeah. Next question up out there.
In regards to other infectious, what kind of preparation is given to the area? Anyone?
Let me, I think this is why they invited me here, to stir things up. I think someone said earlier about public health is local. Yes, it is. It starts local. But there's an overarching philosophical lesson we learned here, is that public health is indeed global. And that we have, there's a Dr. Stella Rayo, I believe her name, she was a Nigerian doctor, who stopped a man coming from Nigeria named Patrick Stewart. He was Ebola positive, and she contained him. She lost her life, and 21 of her staff were infected. 8 of them lost their lives, but they contained Ebola in a city of 21 million people. And what it was is training. I think what we have as public health, I hate to say this, we have failed in many instances in the last few years, last 10, 15 years. It's that the analogy is if a professional athlete says, give me a lot of money and I'll play really well. It's not the way it works. You play really well and then you get a lot of money. And you see something like Ebola that has an incubation period of anything from 3 to 10 days. It's very virulent, it's lethal. This was one we should have seen coming. And actually, if you remember about, a few years ago, we were funded for anthrax, where we were supposed to develop all hazards plans to prepare for things like this. Here recently, there was an exercise by UCLA where they went over the top. They exceeded CDC requirements, but they started the exercise by saying an Ebola patient walks into our facility. But that's not the way it should work. We should now, to earn our paychecks, so to speak, to justify those funds, see these other diseases. We have dengue, we have Chagas, we have malaria, chikungunya, we've got hantavirus, we've got plague that's endemic to the United States. We need to train people, I think we need to get out of this sensation, I think the media sensationalizes it, but it also makes us have tunnel vision about as somebody mentioned, the threat du jour, the pathogen of the day. And I think a true, well-trained workforce is capable of identifying the surveillance, detection, containment, response, and resolution needs to be promoted through training that allows people to identify all these predictable, anticipatable, if that's the word, threats, to include, to answer your question, things like dengue, Chagas, chikungunya. These are things literally right at our border, and they're coming. Malaria, I think, is probably going to make another emergence. But how do we make sure people are trained to differentiate between each one, and to have, again, someone said there's overprotection. You can overprotect yourself. How do we make sure to respond in an appropriate manner where we can test all our response contingencies? And I think that's the key. Once we show that we saw this coming and we were ready for it, that's when we as professionals, we get the good part.
And I think the question was about measles too, right? And it highlights just what Dr. Mangala said, which is the infrastructure and the capacity to respond. By the way, we have a measles vaccine. Very, very, very effective. And what we have seen is kind of a backlash on the science. And you've heard so many of us in the discipline of public health emphasize the science. And we've heard how that sometimes we really have to avoid the politicization of a scientific intervention, right? It has become in the last 12 or 18 months a political discussion when it's been a 5 or a 6 decade success in some ways, back to smallpox vaccination, 100-year success from the ways they first immunized and vaccinated. We've seen decades, if not, in some instances, a century of success at preventing communicable infectious diseases. And now what do we see? Now we see an argument against it based on some social media, some talking head discussion. As public health professions and agencies, we really struggle with the messaging on how to combat hysteria and disinformation. And in measles case, we got a vaccine. We need to be able to say we have a vaccine, and we need to talk about the success of the vaccine, and we need to talk about illness and deaths prevented versus an opinion. And that's one of our struggles. We need to use what we have.
Edgar?
Dr. McGowan, back to you. How is the training resources, or what training resources are available to healthcare workers, and how has that curriculum changed?
I don't feel really qualified to answer that. I mean, I was practicing psychologist and worked for Fort Worth for 10 years, and I spent some time overseas, so I'm not exactly sure of the status of training right now. But I think, going back to what I said, that given this opportunity, like going back to years when so much money was funded for an intentional pathological offense, namely anthrax, to use that to focus not only on the event at hand, but on everything. Let's cultivate the discussion to where we train everybody to be sensitive to a number of these pathogens, like Matt said, measles. Remember, like anthrax, like plague, like Ebola. I think this was a huge, going back to the situation in Nigeria. We're just lucky there. It was so lucky that it didn't jump into such an enormous population where it might have easily been uncontrollable, or much worse than it is right now. But going back to that, I think to use this opportunity to make sure everyone's aware that it's not just this one thing. This may be the apex predator, that we have a lot of other things in the environment that we need to be able to detect and respond accordingly. And Matt mentioned in 1976 they discovered Ebola. They actually researched it in England, and a guy named Jeffrey Platt accidentally stuffed himself with a syringe. They monitored him. He started coming down with Ebola symptoms. They designed a negative pressure ambulance. Police escorted him to a hospital where they evacuated the entire hospital. He was the only one there. He survived. He did have Ebola. He survived. Quarantined everyone, including his police escort. And fortunately didn't spread. Now that's a bit of an overreaction, but it's all they had to work with at the time. So if we can develop a discussion to where what have we learned, how can we adapt it to, like that flow chart that was demonstrated earlier for PPE, for the different symptoms, and how do we err on the side of caution, but not one that inspires panic or overreaction? Because that's where we gain trust. That's where we minimize fear. And that's where, they want to retain us on the roster, so to speak, because we are able to detect all these threats that public health is charged to do.
There's a couple of things that I wanted to kind of add to, Matt mentioned the efficacy of the measles vaccine. So we recently had a measles case in Tarrant County. Somebody, traveled back from India, ended up here, and had measles. So one, our epidemiology team, on top of all the Ebola response and other things that are going on, ended up responding to that situation. Also, we had some contacts that we needed to work with and all of those types of things. But also it brought to attention the gap that we have in our community where people have gotten complacent. And the complacency came from the fact that, well, vaccine was so effective that people thought, oh, this disease is not, a concern anymore. And then the anti-vaccine movement kind of took hold, and now we have gaps in the community. But the efficacy of the vaccine is really key. On its own, it's about 95% effective with one dose. And then the recommendation changed, I think, back in the late 90s or early 2000s. With 2 doses, it is 99% effective. That is one of the most effective vaccines we have out there. Compare that to the hysteria, oh, why don't we have an Ebola vaccine, and the development efforts that are going on now, or the flu vaccine. When it's a good year for the flu vaccine, it's anywhere between 60 to 80% effective, depending on what type of flu vaccine you're getting. On a bad year like we had this year, it's about 23% effective. It is still better than not having any protection, but when you compare to measles, it's 99% effective. Take it. Don't even question it. Just take it. And that's one of those things, if you have a 99% shot at doing something, go do it. Why worry about it? And that's one of the messages that, we really struggle when people start thinking about, all the side effects and things like that. A lot of that has been discredited. There's a study that was published many years ago about linked to autism. And then later that study got discredited. The doctor, lost his license and actually ended up moving to Texas. That tells you Texas has, home for folks, so we have a challenge in our community, so that's something that we need to understand, and we work with our community on that, but that's the gap we have here, is that there are a lot of folks who are not taking vaccines, and public health is constantly reminding that there is a, effort out there that we need to make sure that we protect our community.
May I add one thing? You know how good a job you guys did? This is something that the media never caught on. The fatality rate for people infected with Ebola in the United States is beautiful. Absolutely. That's I think, applaudable. And that shows the type of surveillance, detection, response, and effectiveness we have as a public health and clinical system. That people fail to notice that.
You may want to also add resources on that. We have a lot more resources here in the United States than some of those other countries.
Sure.
I have the privilege to take care of the Dallas Fire and Rescue. I'm the coordinator, and I must say I was really pleased at how we worked with not only the county, but also I was able to contact people at Rescue, and with networking with the different people to make sure that our 3 people that were there were cared for. I'm so glad that they hired an RN to actually work with the firefighters to take care of it. And I think that the city make sure that we work as a team, because we are a team.
I think it goes back to Dr. Richardson. You've got to build those relationships. He and I have known each other for 14 years, back when he got here after the 9/11 event. And that started that work on the anthrax and fairness. We have that relationship. He's first on our calls. We have emails back and forth. We got him involved with our city management first, let them hear it from them exactly what we were dealing with. That allowed us then to be able to go out and do our job. So those relationships are key, and you've got to have them all over the Metroplex to be able to coordinate and design your systems to be able to. Number one, we're there to protect our folks.
Greg, what is your role with Dallas County?
I work with the city of Dallas. We were there to support Dallas County. This was really a health response. The city of Dallas, Dallas County provides, is the health authority for the city of Dallas. So we were, as she alluded to, Dallas Fire and Rescue are our first responders, and they transported Mr. Duncan initially. And then obviously everyone saw the ambulance that was quarantined and everything, whatever. And that was, which was, the bloodborne pathogen technically is really not that different from, an HIV potentially an HIV infected or potentially a person that had been, that I guess would be suspected of having HIV. But while they were trying to get their head around it, they put the ambulance aside. The news found out about it. They flew a helicopter over it, and then it just went crazy from there. Then the homeless guy that was in after that. So then really what happened, the whole thing was it was only 3 people. The biggest deal was the media. That's all that it was. It was a media fracas. Once, I think the local media, after the initial push, they backed off a little bit, but once national got a hold of it, it just blew up and it got out of control. And that was the hardest part about all of it. We generally overall, and I think Zach will agree, we generally have a pretty good relationship overall with our local media. There's a lot on severe weather. There's some gotchas at City Hall, especially with the channel. They like to put us in the line from now and then, but they kind of backed off. And national media came in, CNN, that was mentioned earlier. It was crazy. The fear, it was out there. It was nuts. Our biggest challenge as an office and personally was managing the message, trying to stay in front of it, and it was impossible. Rumors. I was on social media as often as I possibly could have been. I rotated through not only an REOC, but we also had a presence at Dallas County EOC. We had a liaison there 24/7. Whenever they were activated, we had a presence there as well, and we took turns as a staff. We would rotate through there as well. So we were constantly communicating, coordinating, helping them. They were helping us. It was just a collaborative effort on all fronts.
I think one of the things that gets left out is emergency management. That's the key to getting out to the public and getting out and bringing all the coalition together. I think emergency management sometimes gets struck off the radar, but those are the boots on the ground. Those are the people that are making it work.
One example, and the city of Dallas did a phenomenal job. One Saturday morning, I get a call from the media saying Dart's going to shut down the rail line because somebody spit on the rail tracks who lived in the Big Green Meadows apartment. So for 4 or 5 hours, you track that down to realize it's no big deal. But as you pointed out, that's the kind of work between City of Dallas, their staff, Dart, health department staff, that you spend 4 or 5 hours on a Saturday to say, this is nothing.
Well, and that's exactly the example I was kind of alluding to earlier, when some of the decisions that were made were not based on science, but more panning through the history of the public. Oh my God, I'm not even traveling on that train because somebody spit on the track, So, and that's what we try to do in public health, to dispel all those myths and fears and stand by and explain the science that this is not a concern. So that's where public health comes in real handy, and people then appreciate it. But like I said, decisions need to be made on a sound basis of science, and that's how all entities can then continue to operate and be credible.
Two of the most memorable phone calls that I myself personally answered in the EOC. One was from a lady in Florida. I wrote the number down. I didn't know where it was from, so I wrote the number down and I Googled the number later. And I found out from the area code that she was in Florida. Called me from Jacksonville, I think. And she legitimately was concerned, wanted to know where this man had eaten. Had he been out to a restaurant? Maybe he had drank coffee. Did the waitress put her finger in the coffee cup? Was this waitress being monitored? Where was she? Did she pick up his plate? Serious. I mean, she was. I want you to tell your boss. Make sure that he tells the mayor. I want you to tell everybody. I said, ma'am, I will tell my boss as soon as I can. And I absolutely did. And he said, okay. And so I did what I thought I did. Second most memorable, well, not second most memorable, the other most memorable phone call I just was the White House Situation Room. You want to talk to the mayor? You don't want to talk to the city manager? No, we want to talk to the mayor. I'll find him and have him call you back at the number that, it was pretty big deal.
Do we have any more questions? Yes, sir.
It's wonderful to see all these county officials, wonderful job that you're doing. Honestly, I see everything like you mentioned earlier about from the TV viewpoint. And it's true. There's a lot of confusion, a lot of misunderstanding, and miscommunication. Any way that you can do like this and put it YouTube is better than any channel TV. And it's beautiful what they're doing now. And explain so people can understand, because you do it cheaper, you know, the TV is gonna be there, whatever it is, the handle. But if you put this program in YouTube, something like that, people can understand that. And I'm sure millions of people can see it, and that maybe our job is gonna push the Congress and put all senators and all these people to listen to you guys. What is your needs?
Well, actually, there was a panel discussion at TCU downtown Fort Worth, and I was there, and that was live webcast on the internet, and there's a YouTube recording of that that's available on the web. And that explained a lot of the science, because it was right in the middle of the Ebola situation. It explained a lot of the science. I mean, it included myself, included Tarrant County Emergency Management, Fort Worth City Emergency Management, so there were some key people there in the community explaining their angle of what's going on and how those things are. And from that, we've actually, taken on, Public Health in Tarrant County. We've been putting a lot of stuff on the website. I have a director's blog that explains a lot, based on current situations. So we're trying to get up there. YouTube is one of the things that we're trying to figure out a way how to, get all the right equipment, because you wouldn't want to see something that I shot with my cell phone, right? So you would want to see something that's professionally done. So we're trying to get all of that pieces in play so that in the future we can serve our community by doing smaller clips of key messages. So those things are already in play. I'm sure my peer health departments have similar ideas on doing things, but well thought out comment there. Thank you. Very cool.
Are there any more questions? No. Well, I will provide a few closing comments and then we'll wrap up.
I'd first like to say thanks to every one of our speakers today. I don't know if everybody out there realizes it, but they came in here on a complete volunteer basis, and they're giving us their time, their knowledge, and we appreciate that. I appreciate everybody that showed up here today. Appreciate everybody who's watching out there on the webcast. Special thanks to our real good friends at University of Texas Arlington for providing this facility, helping us set this up, all of the support that they give us on a continual basis. So thanks to UTA. And with that, I think we can wrap this up. Once again, thank you, and y'all have a good day.